Great, thank you, Lita. Good morning, everybody. Dr. Alexander Park here. I'm your committee chair, and welcome to Wednesday, June 21, our P&T and DUR board meeting. I'd like to go ahead and call the meeting to order, and our first order of business is to take roll call. So I'll read off the names of the participating attendees, and please say here or present when I call your name. Peter Barkett.
Present.
Thank you. Laura Bestie.
Good morning, here.
Thank you. Virginia Bucola. You may have heard my phone ringing during that.
No, Jenny's having some audio issues, so we can't hear you, Jenny.
Oh, okay. I thought it was my phone drowning out my voice. Okay. Yeah, let's see. Kavita Chawla.
Here.
Good morning. I believe Michael Corsilis is not able to attend today. Dmitry Davidov. Dmitry, are you with us? Maybe not quite yet. John McKay.
Here. Good morning.
Good morning. And Christy Weiland.
Hi, good morning.
Good morning. And we'll move on to the Healthcare Authority members. Laura Crocker.
I'm here.
Good morning. Luke Dearden.
Good morning here.
Thank you. And Lita.
Here.
Donna Sullivan.
She's going to be a little bit late.
Okay, thank you, Lita. Marissa Tabile.
Here.
Thank you. Good morning. Ryan Takatomo.
Alex will not be here today.
Okay. Thank you. Beth Shaw from the DURP group.
Good morning.
Good morning, Beth. Sneha Yadala.
She may be joining us later.
Okay. Andrea Vintro.
Good morning.
Good morning. And from Magellan, Umang Patel.
Good morning.
Good morning, Umang. And our MCO representatives, I'll read off these names. We have Greg Seamus from Molina Healthcare, Heidi Goodrich from Molina Healthcare, Petra Eikeldorfer from United Healthcare, Omar Dowd from Community Health Plan of Washington, and Jeffrey Natividad from Community Health Plan of Washington. Okay, Lita, would you like to go over some meeting logistics?
Yes, thank you. The committee and presenters, you can mute and unmute yourselves, but please mute yourself when you're not speaking to limit the background noise. Presenters, please share your webcams while presenting, and the committee, please share your webcams during discussions and motions considerations. For the stakeholder participation, the chair will first read the list of stakeholder names who pre-registered to speak. We will unmute you. After, the chair will ask if there's any other stakeholders. You can use the raise hand function in Zoom and we'll call on you and unmute you. You can also use the Q&A box and we'll address your questions during the stakeholder time. If you did not fill out a stakeholder conflict of interest form, I'm going to put some questions up on the screen. Please answer the questions and your 3 minutes will start after you answer those questions. And lastly, the meeting is being recorded, so please state your name every time that you speak.
Thank you, Lita. Well, let's move right into it. We have a packed agenda today, lots of great work for us to do. And I'd like to ask Beth Shaw from DURP to kick us off with the targeted immune modulators report.
Okay, I'm just checking you can see the full PowerPoint.
Yeah.
Yes,
okay.
Coming through great.
Okay, and you can hear me fine. I will get started. So yes, thank you. I'm here this morning to present to you the updated systematic review on the targeted immune modulators for Crohn's disease and ulcerative colitis. The presentation will take a standard format, so we'll go through a bit of the background to the report. We'll take you through some of the mechanics of the review, so the PICOs and the key questions and the methods. And hopefully we'll spend most of the time on the findings and ultimately we'll move into the discussion. So first of all, I wanted to kind of Oh, it's not. Is it moving on for you? It isn't for me.
Yeah, it's still on the title slide there. At least for me, it is.
Okay, let me try another option. I will stop sharing that version. Stop share, and I'll just try another one. Right, I'm going to try this version. Let's see if this works. Still not moving on. Apologies for this.
Do you want me to try to share the slides?
Would you mind, Lita? That would be fantastic.
Yeah, sure. Hang on just a second.
I could try one more time. It seems to be working now if you want me to give that a go.
Yeah, you can try it. I'm just opening up the PowerPoint.
Okay. These things are always so tricky every time.
Yeah.
I try to set it up and then right, let's see if this works. No, it's still not working. How bizarre.
Okay, I'll share my screen.
Sometimes there's no rhyme or reason for these things, Beth.
Absolutely not.
It's just the mood of the machine on the day of.
Indeed it is.
Okay, oops, hang on, mine had a delay there too. Okay, there, it should be on screen,
Yeah.
the second
That
one.
looks good.
Okay, great.
Fantastic. Just let me get everything set up here and I should be good to go.
And just say next slide. You want me to
Fantastic.
move on?
Oh, you're a star. Thanks so much, Lita. So yes, this will take the same kind of format that you're kind of used to. As I said, we'll go through the mechanics of the review, but we'll spend most of the time on the findings and discussion. So on the next slide, you can see a list of the common abbreviations that we use in this report. There's quite a few of them, so I won't go through them in detail, and I will call out a few of the important ones as we move through. Many of these will be familiar to you, but some of them are specific to the condition and the drugs that we cover in this report. So moving now into the background. On the next slide, and on the next slide, you can see some background of these two conditions. So Crohn's disease and ulcerative colitis are chronic inflammatory diseases of the GI tract, and they're commonly diagnosed by colonoscopy. Crohn's disease is characterized by inflammation involving the full thickness of the bowel wall at any point from the mouth to the anus. And ulcerative colitis is characterized by mucosal ulceration that's limited to the colon and the rectum. The TIMs, or the targeted immune modulators, are a group of biologic drugs that are used to treat these conditions by selectively blocking the mechanisms that are involved in the inflammatory and immune responses. In 1998, the FDA approved the first targeted immune modulator, infliximab, for Crohn's disease. And since then, a number of additional agents, including biosimilars, have been improved for both conditions. On this next slide, you can see an overview of the drugs. So it's slide 5. Thanks, Lita. So you can see here that there's a number of different drugs included in this report. So this slide provides an overview of the different agents that we've included in this update. We included 11 agents and 6 pipeline drugs. So just as the key to this kind of overview, the agents in the blue boxes are approved for use in both diseases. So they're approved for use in both ulcerative colitis and Crohn's disease. The agents in the pale green boxes are approved for Crohn's disease only, And the agents in the yellow boxes, the slightly kind of peachy colour, they're approved only for ulcerative colitis. The drugs in the white boxes show the pipeline agents. So you can see at the top, we've got these different groups of drugs ranging from the TNF-alpha inhibitors through the integrin blockers and the interleukin blockers, the Janus kinase or the JAK inhibitors, the selective sphingosine 1-phosphate receptor modulators, and the humanized IgG4 monoclonal antibody there at the end. I'll just pause here. There's a lot of information on this slide. So yeah, this gives you an overview of the number of TIMs that are included in this report. Next slide, please. So for this update of an existing report, these are the PICOs that we used. So we have the populations were adults with Crohn's disease or ulcerative colitis. For the interventions, we were looking for TIMS agents that are FDA approved for these conditions, or indeed those agents that are in the pipeline that that are anticipated to be approved. In terms of the comparators, we were looking at other FDA-approved TIM agents, so those head-to-head comparators. But for the pipeline drugs, we also included the comparator of placebo or standard of care comparisons. In terms of our outcomes, we were looking for studies that reported on health outcomes, such as disease remission, clinical improvement, as well as quality of life and safety measures, such as adverse events. And finally, for the study designs, we were looking really only for randomized controlled trials that lasted for 12 weeks or longer. But also for harms, we looked for those cohort studies, again, that lasted 12 weeks or longer, but we were looking for those large cohort studies. So we were looking for studies there that had a minimum sample size of 1,000 participants. Moving now on to the next slide, you can see the key questions for this report. So we were looking to answer the question around the comparative effectiveness of these agents to treat Crohn's disease and ulcerative colitis. We were looking at the comparative harms of TIMS to treat these two diseases, and we also looked for the characteristics of the ongoing studies. So as I've mentioned before, this is an update. So on this next slide, you can see some of the differences that we encountered that we needed to make changes when compared with the previous report. So in the previous report, we'd included two pipeline drugs, pefficitinib, and a pipeline drug that really only has this kind of code name, the PF 04236921. We included those in the prior report, but we excluded them this time because they had reported severe GI adverse events. So really, we're no longer active in that pipeline setting. Because of this, we also excluded 3 previously included studies. One of them was a randomized controlled trial that focused on one of those pipeline therapies, the PF random number. That was excluded because that randomized controlled trial was evaluating that pipeline therapy that's no longer of interest. We also excluded 2 cohort studies because they really didn't report on the comparative risks among the drugs of interest. And really that's what we were using those cohort studies to look for, you know, whether one of the TIMs was exhibiting more adverse events than the others. In this report, we've also included 3 new pipeline therapies that may be of interest. So that's guselkumab, brazikumab, and izencitinib. So we included those 3 new pipeline drugs. Pipeline drugs always cause more pronunciation difficulties, I find. We also reorganized the report a bit because as new evidence gets added, the structure of the report sometimes needs to be adapted. So for example, in the prior report, the 3-armed studies, so often where you've got 2 TIMs and a placebo maybe, or 3 TIMs being evaluated in the same study, those studies were presented together. But for this report, we've split them by comparison. So you may see, for example, a 3-armed study appear 3 times. We also added a section on mixed populations. So you'll see somewhere the agents have been evaluated in a group of people who may have Crohn's disease or they may have ulcerative colitis, and they've not been split out by disease. And as mentioned, we've also split some of those comparisons to hopefully make your job easier. So moving now into the methods. On this next slide, you can see a summary of the methods that we've used. In general, our methods follow standard DUR practice, which you can see in much more detail in the report. But for this update, we searched those electronic databases you can see on the screen from January the 1st of 2019. So that's the date that would have been the end of the last report, through to July 14, 2022. We also searched a number of international study registries and clinicaltrials.gov to identify those ongoing studies. And we evaluated each study. We evaluated each study's risk of bias. We used OpenEpi calculator to do some of those statistical calculations. So things like absolute risk differences, risk ratios, the incident rate ratios, and the associated 95% confidence intervals. We used GRADE to evaluate the overall certainty of evidence by some key outcomes. And as I mentioned, you can see at the bottom those searches that we used for the trial registries for the ongoing studies. On slide 11, you can just see a reminder of the risk of bias that we use. So a study that's assessed as being at low risk of bias usually has clear reported methods, and it explains, the processes that they've gone through to kind of mitigate the potential biases in those studies, as well as some information on conflicts of interest. A study that's assessed as being at high risk of bias has clear flaws that are likely to introduce serious bias into the findings of that study. And on slide 12, you can see again just a reminder of the GRADE certainty of evidence. In this review, we rated 6 outcomes using GRADE. You can see those at the top of the slide. So that's things like disease remission, clinical improvement, as well as safety, with both adverse events and serious adverse events, as well as withdrawals due to adverse events. And specifically for this group of agents, we were looking for information on infection. So this slide shows how each GRADE rating can be interpreted with respect to our confidence in the findings. So something where we assess it as being at high, a high certainty of evidence, we're pretty confident about that finding. And what that means is that if research were to come out next week on the same outcome, we would expect it to be the same. It wouldn't tell us anything different. However, when we're living in that low to very low certainty, we would anticipate, that any research that came out maybe next week, next month, is very likely to kind of change our understanding of those effects. So that's a kind of easy way to think about GRADE. I just wanted to highlight there was one. GRADE is an evolving system. It's been around for many years, and there's lots of work on it to improve it over time. And actually, in this review, we also implemented a small methodological improvement for GRADE. So where there are very few events for an outcome of interest, GRADE now allows us to rate down 3 steps in the system. Previously, we were only allowed to downgrade for 2 steps. But now we've got that opportunity to downgrade for 3 steps. For example, we may have a well-conducted randomized controlled trial, which starts at high certainty of evidence, but there may be only very few cases of serious infections. We know that randomized controlled trials, for a number of different reasons, may not capture rare adverse events very well. So we've got this well-conducted randomized controlled trial with very few cases of serious infections. We can rate down 3 steps to very low uncertainty, because very few events in that context don't really provide enough information for us to assess the comparative risk of harms. So you will see that as we go through the findings, but also again, there's more details about exactly when that's happened in the report. So let's move into the findings. So on slide 14, you can see the literature flow diagram. So for this update, you can see at the top, we screened just over 2,100 abstracts, and ultimately we included 17 new studies. We carried forward 9 studies from the prior report. So bundling all that together, you can see the report now includes 23 studies. Lita, maybe if you just click on the next one, I think a green box might pop up. There we go. And maybe 2 more times, then I think we get the whole 3. Perfect, thank you. So you can see in these green boxes that we have 10 new studies and 4 studies from the prior report. So we've got 14 studies on Crohn's disease. We have 12 studies in total on ulcerative colitis. And then we have 3 studies in the mixed populations. Just to note that the numbers in the green boxes don't add up to 23, which is the number of studies overall that we have in the report because of those mixed population studies. So 6 of the studies report results on both diseases. So that's both Crohn's disease and ulcerative colitis. But overall, there's 23 studies. And you can see on slide 15 how these break down. So of the 23 studies, 6 were included in the prior report, and we have 17 new studies. We have 10 randomized controlled trials and 13 cohort studies. Again, just to note, we use those cohorts for comparative harms only. In terms of risk of bias, the majority of the studies are in that kind of moderate to low risk of bias. However, we assess 6 of those studies as being at high risk of bias. As mentioned, 12 are in ulcerative colitis, 14 in Crohn's disease, and 3 are in that mixed populations. In terms of the key questions, so key question 1 is around effectiveness. We included 8 studies that told us about the effectiveness of these agents and 22 studies that really focus much more on those comparative harms. And in terms of the comparators, we had 17 head-to-head comparisons and 6 in the pipeline drugs. So on the next slide, you can see the structure of the findings. So this is how we're going to kind of move through the report. So first of all, I will talk about Crohn's disease, followed by ulcerative colitis, and then we'll move into the mixed populations. Within each of these sections, I will first report on the benefits of the head-to-head comparisons, followed by potential harms, and then I'll talk about the information that we have on the pipeline therapies. And then to conclude the findings, I will present the evidence on those mixed populations, and this will be more detail than evidence that was included in the prior report. We have found some new evidence. And to kind of help us all in identifying which is the new evidence in this report, we've used blue colour. So you'll see this blue highlight throughout that will highlight those new studies that have been included in this report. So on the next slide, thank you. You can see just some information that hopefully will help us interpret the evidence that I'll be presenting. So these are a couple of commonly used instruments that are used to assess outcomes in Crohn's disease and ulcerative colitis. So the first one is the Inflammatory Bowel Disease Questionnaire, or the IBDQ, and this can be used for either of the diseases in this report. It's a 32-item scale that evaluates 4 domains. So that's bowel symptoms, systemic symptoms, emotional functioning, and social functioning. The score ranges from 0 to 224, with higher scores indicating better health. And the minimal important difference for this scale is 16 points. The second scale is the Crohn's Disease Activity Index, or the CDAI, and this assesses weighted clinical factors with scores ranging from 0 to 600. With this scale, it's the lower scores that indicate better health, with scores below 150 being considered indicative of minimal disease. However, scores above 450 are assumed to indicate severe disease. And for this particular scale, the FDA recommends a minimal important difference of 100 points. Again, there's much more information in the report on this, and you can see that other scales and measures are used across the randomized controlled trials and the cohort studies, but I just wanted to highlight those 2 as being pretty common in this area. So let's move into the findings for Crohn's disease. on this next slide, thank you, Lita, you can see this is an evidence map, really showing the number of randomized controlled trials for the specific comparisons and their risk of bias. So you can see across the top, we've got a list of the terms of interest, and we've got the same list down the side, and obviously where they intersect, you can see that they're comparing. So for example, if we look at that top line, you can see that for adalimumab compared with infliximab, we've got one randomized controlled trial at high risk of bias. We've got one randomized controlled trial at moderate risk of bias, and we've got two cohorts, again, that are at moderate risk of bias. They're all comparing adalimumab with infliximab. For this update, we added one new randomized controlled trial and 6 new cohort studies. And hopefully you can see that the new studies added for this update are marked with a blue frame. So you can see that comparison there in the bottom left-hand side of ustekinumab versus adalimumab. That's one new randomized controlled trial. And then if you look on the bottom line for vedolizumab versus the TNF alpha inhibitors, you can see that group of 6 studies there on the bottom line. So in total, for Crohn's disease, we now have 3 randomized controlled trials and 8 cohort studies for Crohn's disease. So what are those studies telling us? On slide 20, we will start with key question 1. So this is about the comparative effectiveness in Crohn's disease. So for this particular question, the data is limited to 2 head-to-head comparisons. So we've got adalimumab versus infliximab and ustekinumab versus adalimumab. So just if you remember that evidence map. So adalimumab versus infliximab is a comparison we already had in the prior report. And we identified 1 moderate and 1 high risk of bias study for that comparison. Both studies really didn't show any difference in endoscopic or histological recurrence at 12 months or in quality of life. So you can see for that comparison of adalimumab versus infliximab for clinical improvement, no difference, and we're in the kind of very low certainty of evidence. So there's lots of uncertainty around that finding. There's also no difference between adalimumab and infliximab in terms of quality of life. Again, however, we're very uncertain. We also have this comparison of ustekinumab versus adalimumab. And so you can see on the next slide, this is a new comparison. So hence the highlight in blue. So this study was rated as being at moderate risk of bias, and it included 386 participants. And after 52 weeks, the clinical response and various measures of remission were measured, and they did not differ between the treatment groups. And you can see all the different measures here on the slide. So for example, in terms of clinical response, the response rates were 72% for ustekinumab and 66% for adalimumab. However, they were not statistically significant. Similarly, for the remission rates, we've got 65% versus 61%. However, they were not statistically different after 52 weeks of treatment. We also see no different in that corticosteroid-free remission at 52 weeks, or indeed in patient-reported remission at 52 weeks. Again, you can see that similar 57 versus 55%. Across the board for these outcomes, you can see that we graded these as being at moderate certainty of evidence. So we're kind of much more in the reasonably confident area for these particular outcomes and this comparison of ustekinumab versus adalimumab. Moving on to the next slide, we've got information on the comparative harms in Crohn's disease. So for this update, we added that randomized controlled trial, that new randomized controlled trial, and 6 cohort studies. So in total, we have information from those 2 randomized controlled trials that we just talked about and 8 cohort studies, which provide information on the 5 comparisons which are listed here on the slide. So we've got comparative information on the harms for adalimumab versus infliximab from 1 randomized controlled trial and 2 cohort studies. And then we have these other comparisons. So we've got the certolizumab versus adalimumab, from a single cohort study. We've got infliximab versus certolizumab from a single cohort study. We've got that comparison that we've just talked about of upadacitinib versus adalimumab from the randomized controlled trial. And then a number of studies that have told us about the comparative harms between vedolizumab and the TNF-alpha inhibitors. So moving on to what these studies tell us, you can see here that when we're looking at adalimumab versus infliximab, really the risks for harms didn't differ between adalimumab and infliximab. The follow-up time was 54 weeks, so you can see no difference in overall adverse events, in withdrawals due to adverse events, or in serious adverse events or infections. The certainty of evidence for all of these outcomes, however, is very low, so we're very uncertain about these findings. And moving on to the next slide, you can see that when we look at the differences between certolizumab and adalimumab, they only reported on serious infections, but there was no difference between those two drugs, nor was there any difference between certolizumab and infliximab, again, with serious infections only. However, both of these findings we assessed as being a very low certainty of evidence. So again, lots of uncertainty around those findings. So on the next slide, you can see some new information here on that comparison of ustekinumab versus adalimumab from that new randomized controlled trial. And except for a lower risk of injection site reactions with ustekinumab, you can see that overall adverse events, serious adverse events, and risk for infection were similar. What we can see from this, if we just go back to that injection site reactions, you can see that there was a lower risk of injection site reactions with ustekinumab versus adalimumab. So that's 6% versus 11%. You can see, however, that whilst the risk for experiencing any adverse event was similar in both of those groups, it is pretty high. So that first bullet point, you can see the overall rate of adverse events wasn't different between groups, but it was high at 80% and 78% in both in each of those groups at 52 weeks. And similarly for the serious adverse events, they're relatively high in both groups. They're not significantly different between the groups, but at 13% and 16%, they're relatively high. And mostly depending on the number of events, we rated the certainty of evidence across the board here. So it does range from very low to high. So high certainty of evidence for those overall adverse events, ranging to very low for that information on serious infections and opportunistic infections, which were actually pretty rare events. You can see 1 to 3% across those two outcomes. And on slide 26, you can see again this new comparison, new information here on the comparative harms of vedolizumab versus the TNF-alpha inhibitors. And so this new evidence from the 5 cohort studies showed us that across these studies, so nearly 23,000 participants, there were no differences between these two groups of between vedolizumab and the TNF-alpha inhibitors in both serious infections and opportunistic infections. The certainty of evidence, however, was very low. So again, lots of uncertainty. And just to note that that hazard ratio for both of these, for the first bullet point, because we've got 5 cohort studies, we've presented to you the largest study, just to give you some kind of feeling for the numbers across those cohort studies. So just finally, for the efficacy and harms of TIM agents for Crohn's disease on slide 27, you can see just a summary of this, of the information that I've just presented. So the first column shows the comparisons for which we found evidence. The other columns present outcomes that we graded. So that kind of yellow colour indicates no significant differences between treatments. The green colour indicates results that favour the first drug of that comparison. So if you remember that there was fewer injection site reactions with ustekinumab versus adalimumab, and that's what that green box represents. And we also show, you can see the grade certainty of evidence with those kind of those dashboards in each comparison. So let's just finish Crohn's disease with the pipeline TIMS. So on the next slide, you can see a summary of the evidence that we found for these pipeline therapies. We found evidence on 3 pipeline TIMS that are currently not approved for the treatment of Crohn's disease. So that's brazikumab, guselkumab, and mirikizumab. And you can see here, of those 4 randomized controlled trials, 3 of them are placebo-controlled trials. However, we do have that one head-to-head trial comparing guselkumab versus ustekinumab. So what are those randomized controlled trials telling us? On slide 29, you can see again, this is a new comparison, brazikumab versus placebo. It was a single randomized controlled trial with 121 participants, comparing brazikumab, which is an interleukin-23 inhibitor, with placebo. And it was a 12-week study. After 12 weeks, this study really found no difference between the use of brazikumab across a range of outcomes. So you can see no difference between brazikumab versus placebo for clinical response or remission, low certainty of evidence, no difference between groups in either overall adverse events or serious adverse events, nor in withdrawals or serious infections. The certainty of evidence is generally low, with the single outcome of overall adverse events being moderate. So some uncertainty in most of those outcomes. Now looking at the next comparison of guselkumab versus placebo. This assessed different dosing regimens of guselkumab compared with placebo. Guselkumab is also an interleukin-23 inhibitor, like the drug we've just looked at. This study included 246 participants and followed them for 12 weeks. Generally, participants treated with all the doses of guselkumab achieved better clinical response and remission and had a better quality of life than participants in the placebo group. So you can see that information there. So better response, better remission, and better quality of life. However, there's some uncertainty here, with all of those outcomes being graded as low certainty of evidence. And continuing on slide 31, we can also see from the same study that the study detected higher risks for the overall adverse events for guselkumab when compared with placebo, particularly when that higher dose of 1200 milligrams was used. But for serious adverse events and those serious or opportunistic infections, there was no differences between groups. So again, however, these outcomes were rated as being of low to very low certainty of evidence because of the low numbers. So you can see, for example, for serious infections, we're looking at 1.4%, 2.7%, so low numbers, and that's where we've used that kind of downgrading 3 levels that is now allowed in the grade system. So next slide, please. We can look at the findings from that randomized controlled trial comparing directly head-to-head guselkumab and ustekinumab. And ustekinumab, as we heard in the prior section, is already approved for Crohn's disease. So guselkumab is the pipeline therapy here. The trial included 248 participants and looked at them over 12 weeks. And again, this trial tested the various doses of guselkumab versus ustekinumab. At the end of the treatment period, you can see here there was really no difference across the range of outcomes, so response, remission, or quality of life. So there was really no difference between either of these therapies. Again, low certainty of evidence, so some uncertainty in there. And following with this trial, on the next slide, you can see the safety outcomes. This therapy, again, no difference between these groups in terms of adverse events, serious adverse events, withdrawals, or serious or opportunist infections. Again, we're looking at certainty of evidence around low to very low. So, some to lots of uncertainty depending on the outcome. And finally, we're looking at the last comparison here on slide 34. We have mirikizumab versus placebo. So this mirikizumab is one of the humanized IgG4 monoclonal antibodies, and this was compared with placebo. The trial included 191 participants and followed them up for 12 weeks. What this trial showed was that there was better response and remission rates and a better quality of life for patients treated with mirikizumab when compared with patients treated with placebo. So you can see here that the response rates, depending on the different dosage, range from 42% for 56% for mirikizumab, compared with only 34% for placebo. And whilst these results are, encouraging the better improvements with mirikizumab versus placebo, we assess them all as being at low certainty of evidence. So there is some uncertainty around these findings. And really, I think it's saying we need probably more research. And just rounding out this trial, on the next slide, you can see the safety outcomes. So really no difference on these measures of safety between mirikizumab and placebo. Again, low certainty of evidence to very low for that withdrawals due to adverse events. So now if we look at the findings for ulcerative colitis, we start off on the next slide with our evidence map, showing the number of studies for each comparison and the risk of bias. As before, new studies for this update are marked with that blue frame. So overall, we identified 6 new cohort studies that are looking at these comparative harms of TIMS, and we carried over 1 randomized controlled trial and 2 cohort studies from the prior report. So looking now at key question 1, our comparative effectiveness in ulcerative colitis. Overall, we found 1 randomized controlled trial that we assessed at being a moderate risk of bias that compared vedolizumab with adalimumab. This study reported a higher incidence of clinical remission and steroid-free remission at 52 weeks with vedolizumab when compared with adalimumab. And participants randomized to vedolizumab also experienced significantly larger improvements on those quality of life measures. We graded the clinical remission and quality of life outcomes as being at moderate certainty of evidence. However, we assessed the information on corticosteroid-free remission at low certainty of evidence. So we're kind of in the, well, we're pretty confident for remission and quality of life, a little bit less confident around the corticosteroid-free remission. And this is not new information. We didn't identify any new evidence on the comparative effectiveness of TIMS for the treatment of ulcerative colitis. Moving on to our comparative information on harms for TIMS in ulcerative colitis, you can see here we identified 6 new cohort studies. We've got some information that we carried over from the prior report. So this was around that comparison of infliximab versus adalimumab, and there was no difference between these 2 therapies in terms of serious infections. Lots of uncertainty around this. And on the next slide, you can see some of the new information that we found for this report. So this was a cohort study which combined data from both the clinical claims database and randomized controlled trials. So there's just over 5,500 participants, and they were looking at the comparison of tofacitinib versus the TNF-alpha inhibitors. And this study detected a lower incidence of both serious infections and opportunistic infections with tofacitinib when compared with the TNF-alpha inhibitors. And the certainty of evidence, however, was very low. So again, lots of uncertainty around this finding. On the next slide, on slide 41, you can see here, this is some information on the comparative risks of harms of vedolizumab and adalimumab from that randomized controlled trial that we talked about before for effectiveness. And as you can see here, after 52 weeks of treatment, this trial found no difference in risks of harms between vedolizumab and adalimumab, moderate to low certainty of evidence, depending on the specific outcome. And then finally, you can see some new information in this report. So on slide 42, you can see this is looking at vedolizumab versus the TNF-alpha inhibitors. And we find these 4 cohort studies that report a lower incidence of serious infections and serious adverse events with vedolizumab than with the TNF-alpha inhibitors. Again, the certainty of evidence for these was very low. And then finally, in 1 study that we assessed as being at high risk of bias. Again, this study showed that there was no difference between opportunist infections that required hospitalization between the vedolizumab and the TNF alpha inhibitor groups. On slide 43, you can see again this kind of overall summary. Again, that kind of yellow colour indicates no significant difference between treatments, and that green colour indicates results that favour the first drug of the comparison. So let's run quickly through the pipeline, TIMS, for the ulcerative colitis. We've got these 3 randomised controlled trials here, all of which are placebo-controlled trials looking at the efficacy and harms of etrasimod, filgotinib, and mirikizumab. So looking at the first study on slide 45, you can see the etrasimod versus placebo. Etrasimod is an oral sphingosine 1-phosphate receptor modulator. This was a randomized controlled trial with 156 people in it that were evaluated over 12 weeks. And overall, compared with placebo, particularly participants on the higher dose of etrasimod, the 2 milligram dose, they tended to achieve better response and remission rates, and again, better improvement with symptoms compared with placebo, but not so much with the lower dose, the 1 milligram dose. Overall, low certainty of evidence, so there's some uncertainty around those findings. And when we move on to the next slide and look at the safety, you can see here again, no difference between this therapy and placebo, but uncertainty kind of low to very low for these. Moving on to the next slide, you can see the trial comparing filgotinib versus placebo. So this included 571 participants, and filgotinib is an orally administered JAK inhibitor. This is a study that was over 58 weeks, so a bit of a longer follow-up than some of the others that we've seen. And you can see that generally participants in that filgotinib group tended to achieve better clinical response, better corticosteroid-free remission, and an improved quality of life when compared with placebo. However, generally lots of uncertainty to reasonable uncertainty for those. Moving on to the next slide, you can see the information on comparative safety, and really you can see no significant difference across any of those measures of safety between the active treatment group and placebo. And then finally, the final of these 3 trials looking at mirikizumab versus placebo, you can see that this trial included 249 participants and followed them again for that shorter period of 12 weeks. Both doses of mirikizumab tended to achieve higher response rates, better remission and symptomatic remission and quality of life, but that did vary sometimes depending on the particular dose that was being used. So we tended to see better improvements with those higher doses. And then moving on to the information around safety, you can really see that there's no difference between those groups across those different measures. However, lots of uncertainty with low to certainty grade of evidence. So finally, we can move into that group of our mixed population. So on the next slide, you will see the usual one. All of these studies are new, but again, you can see the information on the various comparators as well as the risk of bias. And all of these studies are at moderate risk of bias. So moving on to key question 1 for this group of people. So both Crohn's disease and ulcerative colitis. We actually didn't find any randomized controlled trials in these mixed populations. All the trials are done in either Crohn's or ulcerative colitis. So there's no evidence that we can present to you on the comparative effectiveness in those mixed populations. However, on the next slide, you can see that across the 3 cohort studies that we identified, there was evidence on 10 different comparisons, which are listed here on the slide. I won't go through them all, but you can see they include adalimumab, tofacitinib, ustekinumab, vedolizumab, compared with various other TIMs of interest. So on the next slide, we can run through these relatively quickly. You can see that there was no difference for serious infections between adalimumab versus infliximab. No difference between tafasitamab versus the TNF-alpha inhibitors, and no difference in serious infections between ustekinumab and adalimumab. And just as a kind of overall summary, we'll run through each of these comparisons, but with the exception of one of the comparisons, none of the other 9 comparisons showed any difference in serious infections between TIMs. So they're all showing similar rates of serious infections. So on the next slide, you can see these comparisons. Again, no difference in serious infections with ustekinumab versus infliximab, TNF-alpha inhibitors, tafasitamab. And on the next slide, again, in general, no difference between vedolizumab and adalimumab or ustekinumab, but you can see in that middle one, we do have some information that shows that there tends to be a lower incidence of serious infections with vedolizumab when compared with infliximab. But regardless of that finding, there's still lots of uncertainty around that. And then on the next slide, that final comparison of the 10, looking at vedolizumab, again, no difference between those 2 groups, however, lots of uncertainty. And moving finally into the pipeline TIMs in this mixed population, we didn't find any evidence that met our PICOs. So on the next slide, you can see the standard infographic showing you this information about them. So really no difference apart from that green box where vedolizumab showed lower rates of serious infection. On the next slide, I just wanted to remind you that we also did present some information in the report on some indirect evidence. So there's a couple of recent network meta-analyses that we present to you in the report, 1 on Crohn's disease and 2 on ulcerative colitis. And as mentioned, I don't present them here to you today, but you can find that information in the report. So I will very briefly give you an overview of the ongoing studies. So on this slide, you can see here that we found 29 relevant new, ongoing studies, 25 of which are randomized control trials and 4 of them are cohort studies. 7 of the randomized control trials are in that Crohn's disease population. And for people with ulcerative colitis, we have 18 ongoing randomized control trials and 1 cohort study. And in that mixed population, we found 3 cohort studies that are ongoing at this particular point in time. In terms of the completion dates, the earliest completion date noted is at the end of this year, and that was a single study. And then we have 6 previously included studies that were noted as being ongoing studies. They have now been designated as completed. But again, at the time of this report, we were not able to identify any publications from those studies that have recently been completed. So moving now into the discussion section. First of all, I just wanted to highlight some of the limitations of the report, and there's a few factors that we would like to highlight with you. First of all, although we did add 17 studies, which is a reasonable number of studies, there still remain a limited number of head-to-head studies for these conditions. We'd also like to note that the available randomized controlled trials are really not powered for those harm outcomes, particularly those rare outcomes for things like serious infections. And when we were looking at those cohort studies, those large cohort studies for those rare and serious adverse events, they often have methodological limitations, which limit our ability to make robust conclusions, hence that use of low to very low certainty for a lot of that comparative harm information. We'd just like to highlight that drug manufacturers sponsored all of those eligible randomized controlled trials. And also to note that most of those cohort studies used administrative or claims data, which are useful for various information, but they may not be as valid or reliable as direct measurement in the clinical setting. And finally, this review did not include randomized controlled trials shorter than 12 weeks. We also excluded the smaller cohort studies, with those with fewer than 1,000 participants. Neither did we include data from conference abstracts or press releases, and we also limited the review to studies published in the English language only. So those are just some of the limitations of the report. So moving on to the conclusions. So for this set of conclusions, we're going to limit those to findings that have at least low certainty of evidence. So we're just going to call out some key pieces of evidence for which we have low certainty of evidence or higher. So for Crohn's disease, the head-to-head evidence is very limited. We have evidence from only 3 randomized controlled trials and 8 cohort studies, with data only on 5 possible comparisons out of 21 that we would be interested in. And regarding the specific comparisons, we found no differences in efficacy or harms between the use of ustekinumab and adalimumab, with one exception, where the evidence suggested a higher risk of injection site reactions with the use of adalimumab when compared with ustekinumab. It's important to note that for all of the comparisons, the certainty of evidence is very low. So we've really got lots of uncertainty around these, around the other findings other than these presented on the slide. And for ulcerative colitis, again, a limited amount of data consisting of only 4 randomized controlled trials and 6 cohort studies. Again, out of the possible 28 comparisons of interest, we only had data available for 4. And the only comparison with moderate or low certainty of evidence was for the use of vedolizumab versus adalimumab, which showed no significant difference between those 2 therapies in the risk of benefits and harms. And again, as a note, for all the other comparisons that I presented to you, we're in that very low certainty of evidence. So lots of uncertainty around the findings. And then finally on this slide, just a reminder of the ongoing studies. So on slide 68, you can see, just to note that this is still an area of intense research. We detected 29 ongoing studies, and I'll just leave it at that. There's a lot of research endeavour in this area. So hopefully in the future, where we do have those gaps, where we do have those uncertainties, hopefully we will have much more of that information in the future. But thank you, that's a long report, and I'm happy to take any questions.
Thank you so much, Beth. It's a very complicated topic with complicated drug names, and you did a wonderful job summarizing all that. Thank you. Committee, do we have any questions for Beth from DURP? Dr. Barquette.
Thanks. Just 2 quick questions based on the presentation, very thorough presentation. But first, on the comparison of tofacitinib to, I think it was either adalimumab or infliximab, and the reduced rates of infections. I'm trying to recall, because there's a black box warning with tofacitinib, I was just wondering if we'd also looked at the rates of serious adverse events, including cardiovascular events, or if that signal was too small to make a difference.
So is the black box warning specific at vascular events? So,
yeah, it's specific for
okay.
cardiovascular events. And so I saw that you there were comparisons about rates of infection, but I'm trying to recall now if there was any analysis of comparative rates of just kind of overall serious adverse events, because there is that warning with tofacitinib for cardiovascular events.
I am just looking at the report now to see what we have. It may well be kind of underneath that serious adverse event. So yes, there's some more information in the report on what those specific serious adverse events are. So I'm hoping I'm looking at the right one. So there is information in there. What I would say is that, you know, as I mentioned in the presentation, randomized controlled trials are often not the best way to get that information on serious adverse events, you know, either because they're not long enough or they're not large enough to capture the rare adverse events. So my understanding is that for the information on black box warnings, they use a lot more information like the post-marketing surveillance. You know, there's a lot more information that the FDA can draw on. So we didn't call out cardiovascular events as a graded outcome necessarily, but it is kind of hidden under that serious adverse events. I don't know if that's really answered your question.
No, I think so. I was kind of there's a lot kind of coming at me, and so I think that makes sense that it was included in the serious adverse events, and overall the serious adverse events there were no statistically significant differences. One other question on the guselkumab studies. It was interesting when guselkumab was compared to placebo for Crohn's disease. There was a trend toward, with increasing dose, decreasing rates of remission and efficacy, which I thought was interesting, and kind of wrote it off. But then when guselkumab was compared to ustekinumab, the same trend kind of played out, and I was wondering if the authors of either of those studies had any comments, thoughts, discussion around what seemed to be a trend toward decreasing efficacy with increasing doses of guselkumab, which would have expected the opposite.
It's a great observation, and I don't know. I'd have to dig into those individual studies to see if the authors have that. I can find that for you. Quick look.
Thanks.
Thank you, Dr. Barquette. Great questions. Raises another question for me, which I think is for our partners at HCA. Guselkumab being one of those drugs that's not approved yet for indications in the GI class, but they are approved in the next section for RA and AS. Are we doing these motions separately? And we would be able to parse out the drugs for each motion under the TIM class?
Hi, Alex, this is Lita. In the TIMS motion, we do one motion because the drugs overlap, but here I can pull it up here. So this is the last motion here. So if there are differences between these, we can split the motion and talk about which indications the drugs that the motions that the drugs, I'm sorry, that the committee wants to make the motion for which drugs.
Got it. Okay. So Beth, we might hear more about guselkumab in the next the surveillance update that you have for us. But as far as Crohn's disease and UC is concerned, is it FDA approved for either of those indications?
I don't believe guselkumab is. I think it's pipeline for both.
Okay.
Both of these. And I've just looked at the study that Dr. Barquette mentioned, and I can't see anything obvious about them explaining, the differences. It may well be that they're kind of just, that they're not statistically different, so they're kind of viewing them as being the same, but they don't really explain those the trends that you observed.
Okay, committee, thank you. Any other questions for Beth before we move on to stakeholders? Okay, let's move on to stakeholders. I only have one on my list, which is Aaron Nowak from AbbVie. And I believe, Aaron, you're going to be representing two products. The committee has received your conflict of interest form. And when you begin your presentation, if you wouldn't mind introducing yourself, who you're speaking on behalf of, and if you have any conflict of interests to report. And Lita will start your time.
Okay.
Which I think is 5 minutes for two products.
Thank you. Can you hear me?
Yes.
Great. Thanks a lot. Hello, my name is Erin Novak, and I am a medical outcomes science liaison with AbbVie Medical Affairs. Thank you for allowing me time to provide information on upadacitinib, or brand name Rinvoq, and risankizumab, brand name Skyrizi. for which I will be providing information right now on ulcerative colitis and Crohn's disease. First, I will review upadacitinib, an oral JAK inhibitor, now with 7 indications, including both moderately to severely active ulcerative colitis and moderately to severely active Crohn's disease, both in adults who have had an inadequate response or intolerance to one or more TNF blockers. For clarity, Crohn's disease for upadacitinib was not included in this review, but it was recently approved in May of this year. For ulcerative colitis, the indication has an induction dose of 45 milligrams once daily for 8 weeks. And in Crohn's disease, it is 45 milligrams daily for 12 weeks. The recommended maintenance dose for both indications is 15 milligrams once daily, and a dose of 30 milligrams may be considered for patients with refractory, severe, or extensive disease. Please see the full prescribing information for dose adjustment recommendations in specific populations, as well as limitations of use. For ulcerative colitis, upadacitinib met all primary and ranked secondary endpoints in placebo-controlled pivotal trials, including superiority in clinical remission versus placebo at 8 weeks and 52 weeks. The primary endpoint of the induction trials was clinical remission at 8 weeks, resulting in treatment differences of 22 and 29% over placebo. The primary endpoint in the maintenance trial was clinical remission at 52 weeks, and doses of 15 and 30 milligrams once daily demonstrated treatment differences over placebo of 31 and 39% respectively. For Crohn's disease, upadacitinib met the co-primary and key secondary endpoints in clinical trials. Results mentioned will pertain to those in the biologic failure populations. Rates of clinical remission at week 12 of the 2 induction studies were 36 and 42% versus 18 and 7% for placebo. The rates of clinical remission at week 52 of the maintenance study were 35 and 54% for the 15 and 30 milligrams respectively, versus 13% for placebo. Rates of endoscopic response at week 12 were 34 to 39% for upadacitinib 45 milligrams versus 3 to 10% for placebo. The rates of endoscopic response at week 52 of maintenance were 22% for upadacitinib 15 milligrams, 42% for upadacitinib 30 milligrams, and 5% for placebo. Other endpoints that were achieved over placebo included clinical response at 2 weeks, improvement in fatigue at 12 weeks, corticosteroid-free clinical remission, and endoscopic remission. For complete safety information, including boxed warnings and other warnings and precautions, please reference the prescribing information at rxabbvie.com. Next, risankizumab or Skyrizi is an interleukin-23 antagonist with 3 indications, including the treatment of moderately to severely active Crohn's disease in adults, which has a recommended induction dose of 600 milligrams via intravenous infusion at weeks 0, 4, and 8. The recommended maintenance dose is 180 or 360 milligrams, injected subcutaneously via an on-body injector at week 12, with a training from a healthcare professional, and then self-administered every 8 weeks thereafter. At the approved doses, risankizumab met both co-primary endpoints of clinical remission and endoscopic response at week 12 and 52 in both biologic naive and biologic experienced patients. Rates of clinical remission at week 12 in the 2 induction studies were 45% and 42% for risankizumab versus 25 and 20% for placebo. The rates of clinical remission at week 52 of maintenance were 57% for 360 milligrams and 61% for 180 milligrams. Rates of endoscopic response at week 12 in the 2 induction studies were 40 and 29% for risankizumab versus 12 and 11% for placebo. And the rates of endoscopic response at week 52 of maintenance were 48% for risankizumab 360 milligrams and 50% for 180 milligrams. And then 22% of patients responded to risankizumab induction therapy, then were randomized to placebo in the maintenance period at this endpoint. For complete safety information, please reference the prescribing info at rxabbvie.com. And providers of patients with moderately to severely active Crohn's disease are looking for a treatment that will offer rapid onset, lasting remission of symptoms, and that enable endoscopic improvement, which are a part of the updated AGA and STRIDE-2 recommendations. And given the ability to achieve these endpoints, coupled with a favorable benefit risk profile, I want to close by respectfully asking that upadacitinib or Rinvoq be added to the state preferred drug list for all indications, including ulcerative colitis and Crohn's disease, and risankizumab or Skyrizi for Crohn's disease. Thank you for your time and consideration, and I'd be happy to answer any questions that you may have.
Thank you, Erin, for your presentation. Committee members, any questions for Erin from AbbVie? Okay, hearing none. Are there any other stakeholders that have cropped up, Lita?
Yes. If I'm saying this right, Uche Mordi.
You are saying it perfectly, actually.
Oh, thank you.
Thank you. Oh, okay, good afternoon. My name is Uche Mordi. I'm a pharmacist by training and currently work as a field health economics and outcomes research scientist with Bristol Myers Squibb. Today, I'll be presenting relevant clinical updates for Zeposia, or ozanimod, which is a once daily oral sphingosine 1-phosphate, or S1P receptor modulator for the treatment of moderately to severely active ulcerative colitis in adults. Zeposia offers both a novel mechanism of action as a S1P receptor modulator, and by label, it is the only oral option available for use prior to biologics in the moderate to severe UC space. The True North open label extension, or OLE study, evaluated the long-term safety and efficacy of Zeposia in UC. All patients received Zeposia 0.9 milligrams regardless of prior treatment assignment and the parent trial. The interim analysis reported results up to 142 weeks. Overall, the total exposure of 1,201 person years and a mean exposure to Zeposia of 1.5 years. Efficacy endpoints were evaluated at weeks 46, 94, and 142. When we look at the results for all 823 patients included, at week 142, clinical remission was achieved in 45%, clinical response in 86%, endoscopic improvement in 49%, and corticosteroid-free remission, which is important for disease control, in 40% of patients. Zeposia offers patients with a tolerable safety profile, as demonstrated in the True North OLE. Treatment emergent adverse events, or TEAEs, occurred in 75.3%. Serious TEAEs occurred in 12.8%, and TEAEs leading to discontinuation occurred in 4.7% of patients. Zeposia is an oral selective S1P receptor modulator appropriate for patients with moderate to severe UC that can be used in the first-line setting prior to biologics. These findings demonstrate the evidence of long-term durability and tolerability of Zeposia in UC. And with that, we respectively request that Zeposia be added to the PDL in accordance with the FDA-approved label. Thank you for your time and opportunity to speak.
Thank you very much. And I don't see that you did the COI form ahead of time. Do you have any conflicts of interest other than your pharmaceutical representation?
No, no other conflicts of interest. Thank you.
Thank you. Any questions, committee? Okay, hearing none. Thank you very much. Lita, are we good to move on to the TIM surveillance update?
Yeah, this is Lita. I see no other stakeholders, but Peter Barquette had a question, and if Beth is still on, were the biosimilars, so in particular Amjevita, reviewed in had a full review like the other drugs so that they could be included in a motion? I'm
still on, and I'm just checking the
okay,
report.
great.
But
I
yes,
saw it in the report, but just wanted to see if the review, if there was a complete review done on the biosimilars. I know there's about 4 or 5 called out in the report.
we definitely looked for them. They're in the intervention list. I would imagine that it will be in the detail. We've kind of grouped them by their, by the groupings. So we did look for studies that looked at biosimilars. I mean, I think I'd just remind you that what we see from those kind of overall evidence maps is there's really not a lot of those direct head comparisons. But yeah, we certainly looked for them.
This could be a good moment for the committee to review that angle. If someone from the HCA could comment for us how biosimilars are handled with regard to the TIMS class. I think specific.
Hey,
Yeah.
Dr. Park, this is Luke Dearden from HCA. So as far as the adalimumab or Humira biosimilars go, we do consider them reviewed, and they will be eligible for being preferred on the Washington preferred drug list upon review. So that they have been reviewed as far as we're concerned.
Okay. Do they need to be called out in the upcoming motion?
I would say that because and this is Luke again, that because the ingredient name adalimumab is called out, that includes the biosimilars.
Okay. And what about, let's see, there's another infliximab?
Yes, the infliximab biosimilars are already included, and there are several products that are already available and in use.
Great.
So they're included as well.
Okay, thank you. I hope that helps, Dr. Barquette. Great question about the biosimilars.
Alex, this is Donna. It wouldn't hurt, just for the record, to include, you can list off the names of the drugs and just state and any of their biosimilars, if applicable. I don't think you have to say it after every drug, but just in general, so that we understand, 5 years from now, when we come back and look at this motion, that we intentionally included biosimilars in the motion.
Great, okay. Thank you, Donna. We'll make a note of that
Okay.
when we get to the motion.
And so, like, including their biosimilars when available, I think would be probably the best way to state that.
Okay. All right. And before we get to that work, I think we have one more presentation to go through, Lita, is that right?
Yes, so.
Okay, and
Sneha, are you on?
Yes, can you guys hear me?
Yeah, and do you want to share your own slides, or do you want me to share them?
I can try sharing. Okay, can you guys see the screen?
yes.
Yes.
All right, take it away whenever you're ready.
Yeah, thank you. Good morning, everyone. I'm Sneha Priyadula, Research Associate from Center for Evidence-Based Policy, and I'm here to present target immunomodulators for rheumatoid arthritis and alpha-1 spondylitis surveillance report. I'll start a bit with the topic history and background, followed by PICO's key questions and how we developed the methodology and what we refined, and end up with a summary. So coming to the topic history, the first report was made on December 2005, and later on we have 8 updates. The latest update was done on March 2022. Coming to a little background, rheumatoid arthritis is a chronic inflammatory autoimmune disease that affects the joints and progressive erosion of bones. And coming to alpha-1 spondylitis, it is a chronic inflammatory arthritis that affects the axial skeleton with a prominent involvement of spine and sarcoiliac joints. Coming to the target immunomodulators, it's a biological drugs that are approved for RA and AS conditions, and by this works by selective blocking mechanisms involving inflammatory and immune responses. Intercept is a first team approved for RA condition in 1998 by US FDA, and the same drug has been approved for AS condition in 2003. Apart from that, we now have several additional agents and biosimilars for treating these conditions. Coming to the interventions. So as you can see my screen, there are a list of interventions falling under the category of TNF-alpha inhibitors, interleukin 17A, 6 and 1 inhibitors, and we have JAK inhibitors and anti-CD20 antibiotics and selective T cells co-stimulatory modulators. As you can see, the gray boxes represent the TIMs approved for both RA and AS conditions, and green boxes represent the TIMs approved for RA condition, and yellow box represent the TIM approved for AS conditions, and white boxes represent the pipeline drugs. Moving on to PICOs, so the population of our interest are adults with moderate to severe RA conditions and adults with AS conditions. And as you can see, the list of interventions I showed in the earlier slide are our interest. And the comparators are we went for head-to-head comparisons for FDA-approved drugs, and for pipeline drugs, we included any listed TIMs or standard of care and placebo. Moving on to our outcomes, we are interested in health outcomes and harms. The health outcomes include quality of life, functional capacity, clinical improvement, disease remission, pain, and reduction in number of swollen and tender joints, and reduction in disease-related hospitalization and disease-specific mortalities, and joint destruction, steroid withdrawal, and dose escalation. Coming to the harms, our interest are overall adverse events, withdrawal due to adverse events, serious adverse events, and specific adverse events, and also mortality rates. Coming to study designs, we are interested in randomized control trials with 12 or more weeks of study duration. And we also included retrospective and prospective cohort studies if they met the criteria of 12 weeks or more study duration, minimum sample size of 1,000 patients, and the statistical analysis adjusted for any confounders, and if they provided us the direct statistical comparison between drugs. Coming to the key questions, we are interested in understanding the comparative effectiveness and harms, and see the variation by subgroups, which includes age and racial groups, gender, comorbidities, and patients taking any other commonly prescribed drugs, and patients with early versus established diseases. And finally, we also try to understand the characteristics of ongoing studies. And coming to the methodology, we started this methods with the search of registered trials, which include clinicaltrials.gov, Scan Medicine, and WHO websites, and also any new drugs or new indications seen in FDA websites. When we identified these trials, we then went through the Ovid Medline and Google Scholars to see if there are any available publications of these RCTs or cohort studies. And to understand any new FDA actions, we have went through the IPD Analytics website and FDA website itself. All this searches covered from July 2021 through Feb 2023. Moving on to the findings. In this period of search, we found 3 RCTs and 2 retrospective cohort studies. And the first RCT compared the pipeline drug with adalimumab in patients with moderate to severe RA. And we have a SURPOSE trial which compared the secukinumab with adalimumab biosimilar on spinal radiographic progression. And then we have one study which compared the safety outcomes in tofacitinib versus other TNF inhibitors. And in retrospective cohort studies, these studies assess the safety of cardiovascular events and risk of malignancies in patients with RA, who are treated with tofacitinib with TNF and TNF-alpha inhibitors. And coming to the characteristics of these studies, the first study was conducted in adults with moderate to severe RA condition with a sample size of 48, and they have the interventions of interest were pipeline drug, which was compared to adalimumab and placebo, and the outcomes of interest were disease activity. This trial lasted for 24 weeks. And SURPOSE trial was conducted in biologic naive patients with AS conditions and included sample size of 858, which compared the secukinumab with adalimumab biosimilar. The outcomes of interest were disease activity and remission rate, and this study lasted for 1 or 4 weeks. And then we have oral surveillance study, which was performed in patients with RA aged from 50 and greater years, and who has one or more additional cardiovascular events. This study has a sample size of 4,000 plus patients, which estimated the effectiveness of tofacitinib with other TNF-alpha inhibitors, and the outcomes of interest were treatment emergent adverse event, and this has a 6 years of trial duration. Then coming to the characteristics of cohort studies, there are STAR RA studies, which were conducted in patients with rheumatoid arthritis, and the sample size is 80,000 plus, and these are focused on safety outcomes of cardiovascular events and risk of malignancies. Then coming to the ongoing characteristics of ongoing studies, we have identified 18 ongoing studies for this topic, and there are 2 studies on axillary spondyloarthritis, which has sample size of 300 and 305, with estimated completion dates of Feb 2022 and November 2024. And then we found one trial which compared different classes of TIMS with a sample size of 75 and completion dates of December 2024. And then we find 5 RCTs for abatacept for RA condition with a sample size ranging from 20 to 300 with the completion dates of November 2022 to June 2023. And then we found 4 RCTs of baricitinib for RA condition, the sample size ranging from 178 to 2600 with estimated completion dates of December 2024 to July 2025. And we found 3 RCTs for etanercept for RA condition, and the sample size ranging from 144 to 226 with the estimated completion dates of Jan 2021 to March 2023. Then we have one study which compared upadacitinib with adalimumab for RA condition with a sample size of 40 patients and a completion date of June 2023. And we found 2 RCTs for pipeline drugs which compared the pipeline drugs to placebos with the sample size of 76 and 385 and completion dates of May 2020 to November 2021. Then coming to the characteristics of ongoing studies, we have 2 studies for axillary spondyloarthritis which compares secukinumab with adalimumab biosimilar or TNF-alpha. Both are open label studies and are in phase 3 and phase 4. The outcomes of interest were clinical improvement, remission rates, and adverse events. And then we have one trial with multi-class TIMS which compared between TNF-alpha inhibitors, interleukin inhibitors, and januskinase inhibitors. It is also an open label study conducted in RA patients, and the eligible outcomes were disease activity and quality of life. Then coming to the 5 studies which are conducted in rheumatoid arthritis patients, which compare the abatacept with other TIMS and methotrexate. Most of the studies are open label except one study which was single blinded, and all the studies are all these trials are in phase 3 and phase 4. The outcomes of interest were disease activity, disease remission, quality of life, adverse events, and treatment emergent adverse events or clinical improvements. And coming to the baricitinib, there are 4 studies which are conducted in RA patients, and most of the studies are in phase 4 and one study is in phase 3. They are the phase 4 studies are open label and phase 3 study is in triple blinded study. And the eligible outcomes for these studies were disease activity, adverse events, remission rates, disease progression, and serious adverse events. Then coming to there are 3 studies in which were conducted in etanercept, which was compared to other TIMS, and all these studies were conducted in rheumatoid arthritis patients. They were evaluating the remission rates and retention rates and disease activity for these drugs. And we have one study which compared the upadacitinib versus adalimumab, which is in phase 4, it's a single blinded study, and they were looking for retention rates, quality of life, and disease activity as their outcomes. Then coming to the pipeline drugs, we have one study which is in phase 3 conducted in RA patients, which was comparing the pipeline drug with the placebo and and disease modifying anti-rheumatoid arthritic drugs, which is a blinded study, and the outcomes of interest were disease activity, remission rates, quality of life, and adverse events. And then we have one study which is currently in phase 2, conducted in AS patients with evaluating the bevacizumab with the certolizumab and placebo. This is also a blinded study which was evaluating the clinical improvement, pain, remission rates, adverse events. And then moving on to new FDA actions. So we found 2 new biosimilars for the adalimumab, which are TNF-alpha inhibitors. Route of administration is subcutaneous, and this particular biosimilars are approved for both RA and AS condition in December 2021 and December 2022. Then moving forward with the new indications, we found new indications for janus kinase inhibitors, tofacitinib, which are approved for treatment of adult patients with active ankylosing spondylitis who has inadequate response or intolerance to one or more TNF-alpha inhibitors. And then we have upadacitinib, which has been approved for adults with ankylosing spondylitis condition in April 2022. Then moving to harms and warnings, FDA has issued 3 new warnings for the teams used for RA and AS conditions, which follows as tocilizumab in December 2022 was issued with box warning for the risk of serious infections leading to hospitalization or death. And also, there is increased risk of hepatotoxicity with this drug. And upadacitinib was issued with a box warning to discontinue the therapy if there are any serious hypersensitivity reactions. And baricitinib was issued with a box warning in December 2021 for increased risk of all-cause mortality, malignancies, and major cardiovascular adverse events based on the clinical studies. Then coming to the summary on our new clinical evidence and FDA action since the last report, we found 5 new original studies, out of which 3 are RCTs and 2 are retrospective cohort studies, and we found 18 ongoing studies in which 2 are placebo-controlled trials. For FDA actions, we found 2 new biosimilars and 2 new indications and 3 new warnings. So, yeah, thank you very much for the opportunity and happy to take any questions.
Thank you, Sneha. Questions from the committee? Great presentation, great update. I had a question about the new box warnings on tocilizumab, upadacitinib, and baricitinib. I know this is just a surveillance update, but were there any, did you see anything in the literature that those drugs seem more likely to cause those harms than similar drugs by class of action within their class?
If I recollected correctly, I have seen studies reported in FDA website itself when they have these updates. We didn't dig into deeper details, but I think they are in the FDA website.
Absolutely, and just a reminder of what we do with surveillance. We just kind of provide information on what's changed. We don't, as you say, Sneha, we don't do that deeper dive into exactly what the studies are showing. So as we talked about before, the FDA can draw on different things for their boxed warnings, and that would be something we'd look at if we updated this report. But at this point, we just provide the information.
Okay, thanks. Actually, Beth, wasn't tocilizumab in the GI section as part of the updated systematic review? Was there anything there about whether that was more dangerous?
Again, I'm just going back to the report just to check, because it's such a long list of drugs.
It's a complex list of drugs, absolutely.
The tocilizumab is not in the ulcerative colitis and Crohn's disease report. That wasn't an intervention of interest.
Okay. I got that mixed up, I think, with tofacitinib. Okay, thank you. Okay, if there are no other questions from the committee, we should move on to our stakeholder. And I think we get to hear again from Aaron Nowak with AbbVie.
Great, thank you. Hello again, my name is Erin Novak, Medical Outcomes Science Liaison with Medical Affairs at AbbVie. Thank you for the opportunity to provide information on upadacitinib, or brand name Rinvoq again. 2 of the 7 FDA-approved indications for upadacitinib include moderately to severely active rheumatoid arthritis and active ankylosing spondylitis in adult patients following inadequate response or intolerance to 1 or more TNF blockers. First, for RA, the efficacy and safety were assessed in the SELECT RA clinical program, which consisted of 6 phase 3 randomized double-blind multi-center studies in almost 5,000 adult patients with moderate to severe RA. 2 studies, SELECT Beyond and CHOICE, assessed upadacitinib in patients who were biologic inadequate responders. Across the 6 US phase 3 SELECT trials, upadacitinib met all primary and ranked secondary endpoints, and uniquely, upadacitinib has demonstrated inhibition of joint damage in its approved population of methotrexate inadequate responder patients. In absence of tight disease control, irreversible joint damage may occur, contributing to patient disability. The American College of Rheumatology guidelines for RA recommend a treat-to-target approach aiming for clinical remission, or if not achievable, a state of low disease activity. This improves physical function and mitigates against further joint damage. However, many patients are not achieving the recommended targets, leaving opportunities for additional treatment options such as upadacitinib. Second, for ankylosing spondylitis, the efficacy and safety were evaluated in 3 clinical trials. The SELECT Axis 2 clinical program consisted of 2 studies enrolling non-radiographic axial SPA patients and difficult to treat biologic inadequate responder AS patients, where upadacitinib achieved the stringent primary endpoint of ASAS-40 at week 14. Efficacy was seen also as early as 2 to 4 weeks and was maintained out to 52 weeks. Of great clinical importance, significantly more upadacitinib treated patients achieved a state of low disease activity, as well as rapid improvement in total back pain and morning stiffness versus the control groups at week 14 and 52. The latest integrated safety analysis for upadacitinib included over 6,900 individual patients and over 15,000 patient years of exposure, with no new safety signals identified. Please see the prescribing information at rxabbvie.com for safety information, including the boxed warning and other warnings and precautions. And given upadacitinib's ability to achieve these clinically important endpoints, coupled with a favorable benefit-risk profile, I want to close by respectfully asking that upadacitinib or Rinvoq be added to the state preferred drug list for all indications, including RA and AS. Thank you for your time and consideration, and I'd be happy to take any questions that you may have.
Thanks again, Erin. Questions for Erin from the committee? Okay, hearing none. Did any other stakeholders pop in, Lita?
This is Lita. I don't see any other hands raised.
Okay. Let's turn to our...
Sorry, I was just going to say that rheumatoid arthritis and ankylosing spondylitis was a surveillance, so that needs to be accepted by the committee.
Right. Let's see here. Let's just address that. I'm just looking at the list of drugs, which seems to line up with what was in the surveillance report, at least by my eye. Committee members, feel free to jump in if that's not correct. Lita, I don't see that ozanimod was part of the surveillance.
So this list of drugs is for both reviews, both Tim's reviews. So we've done one motion in the past. So you can see here I've listed out plaque psoriasis and psoriatic arthritis, as well as the other 2. So this is all drugs in both reviews.
Got it. Okay.
And then the grayed out ones were not reviewed this time, but were reviewed in the last.
Got it. Okay, so the first motion before us is to approve the surveillance report for the plaque psoriasis, psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis class.
Actually, it's
adequate.
only for the rheumatoid arthritis and the ankylosing spondylitis, because the plaque psoriasis and psoriatic arthritis was a full report.
Right. Thank you for clarifying that. So do we need it? Is that the motion we're looking at right now, Lita? One that you have up?
Yeah, so right now, first you just need to say if that surveillance report was adequate for you to make a motion about the rheumatoid arthritis.
Okay, committee. We will entertain a motion.
Well, first just accept the surveillance report or don't. You can say you can't make a motion on the rheumatoid arthritis and ankylosing spondylitis, and you need a full report, or if you feel that you can make a motion on those two subclasses.
So we need a motion from the committee on accepting the surveillance.
Just, yeah, just saying if you accept that surveillance report. So we had a full report first, and then we had a surveillance.
Right.
So is it saying this is Kavita Chatla. Is it saying I move to accept the surveillance report as adequate?
Yes, that is fine. Thank you.
We have a second?
A second.
Who was that?
That's Dmitry Davidov.
Thank you. Good morning. All those in favor, please say aye.
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 Any opposed or abstentions? Okay, hearing none, and the motion passes. So the committee feels good about the surveillance report for RA and AS. And now we turn our attention to the motion for the class.
This is Laura Bestie. So we discussed the class for Crohn's and ulcerative colitis, but I don't see what's included.
I note that too. Thank you, Laura. Lita, can we add that to the title of the motion?
Sorry about that.
Is that a separate motion?
Lita, I think you said that we were going to do one motion for TIMS across both disease class groups.
It looks like, hang on just a second. Let me sorry, hang on just a second. Looks like I pulled out the wrong subclasses.
That looks good. Do you mind copy and pasting the prior motion?
So I didn't realize, since we have the different subclass, so we don't have psoriatic arthritis and plaque psoriasis. So I'm going to change that with the Crohn's disease.
Great, thank you. Do we need to, let's see, I think the list of drugs, well, they're not alphabetical. All right, let me see here.
I can repaste it in here. Here, I'll do this. And then if you want me to remove the ones that were not reviewed, these grayed out ones, I can do that as well.
Yes, please.
Okay.
We get to see your wonderful formatting skills on the fly here, Lita.
There we go.
So this is Laura Bestie. Just to confirm, didn't we review the guselkumab for Crohn's?
Let's
Or was
see.
it because it was a pipeline? It doesn't.
Yes, it was correct, Laura. It was spoken about, but it's not FDA approved. But I think it is FDA approved in the other class, if I'm not mistaken.
Which drug name was that?
Guselkumab. Oh, you know what? It's a psoriasis, psoriatic arthritis plaque psoriasis drug, so it doesn't apply to the classes we discussed today.
But it was in the review because I didn't gray it out. So it was in one of them. Can pull up the report.
It was in the UC and Crohn's review,
Correct.
Let me double
but not
check.
FDA approved. It's pipeline for that class.
I'm just gonna search it real quick.
So if you go to table 1, Lita, that will show you all the included drugs. So that's on page 6.
Okay, great, thank you.
And then moving on to page 7, you can see the pipeline ones that at the time of the report were not approved.
Okay. Oh, I thought you had said usteknu, I can't pronounce this. Ustekinumab. Which drug again?
I think it was the guselkumab.
Oh, golselkumab.
Yeah.
Okay, that one.
So that was in the report, but it was as a pipeline, so it's not approved.
Oh, I see, and I have, yeah, I deleted it here because it was grayed out. So just look at this list here is what the motion is on. If it's grayed out here, it means it wasn't reviewed. So this is the list of drugs that you'll make the motion on here.
It's a complicated list of drugs, committee. We can use everybody's eyes to make sure that we've got the right ones. So we don't want the pipeline drugs, and we don't want drugs that have anything to do with plaque psoriasis or psoriatic arthritis that are TIMs, but were not reviewed today. This looks okay to me. Lita, to Donna's earlier point, I would recommend that we add after the big long list of drugs, when we say that I move that the drugs are efficacious, we could do comma, including their applicable biosimilars when available. Great, thank you.
This
Call
is
up-
Laura Bestie again. I just had one more comment. So when we're stating they're efficacious, do we have to, because they're not efficacious for all the indications that we're listing, do we have to say for their approved indications? Or wait, maybe it does.
Well, we said it in the beginning of that sentence,
Yeah,
but
it says it afterwards, right?
I think it would add some clarity if you want to recommend some language. I can see where you're going with this.
You want to say are efficacious for their approved indications?
Correct.
Okay.
Donna, it's Alex. Your question for you: the biosimilars, are they able to be therapeutic interchange for the reference product at this point?
No, they are not. I don't think they're at this point in time, and I could be wrong. I don't think there's any interchangeable biologics that have been approved or biosimilars that have been approved, other than possibly some of the insulins that became biologics after they had already been approved.
Okay, so none of the monoclonal antibodies yet. Okay.
Yeah.
And then just call out for the committee. When we've done these kinds of motions in the past, we have sometimes called out drugs that can be therapeutic interchanged. Typically that's drugs within a very narrow class, but because these TIMs have multiple different mechanisms of action, in the past when we've done this motion, we've not opened that up. And so that language remains. Unless you feel like you want to make a motion to change it or recommend different language based on the updates we heard today. Dr. Barquette, I see you have your hand up.
Yeah, just a quick question about that process. So if we wanted to establish therapeutic interchangeability, say like Inflectra and Remicade or Amgevita and Humira, what is the typical process like? Would that come back in a second report looking at the comparative safety and efficacy data, or would we just include it now? I don't think the report like specifically looked very closely at that. I've seen some of that data elsewhere, but is that something that you typically would tag on to this motion, or that would be brought back to look at more kind of explicitly?
Great question. I'm going to turn to Donna Sullivan.
Hey, this is Donna. That is a good question. Normally, I think it depends on what you feel clinically comfortable with. If you feel like these are just the same drug, and if the whole biosimilar conversation hadn't played out in the marketplace like it did, would you have been comfortable with just treating these like another generic where they would just be interchangeable? I think you can, because we have therapeutic interchange, we can consider them to be therapeutically equivalent and make them interchangeable because of state law, just like we would allow somebody to change, Prilosec for Prevacid or something like that. But I think that's completely up to the committee on how you want to handle that.
So let me ask a clarifying question as a follow-up to Dr. Barket's question. Are all the biosimilars for infliximab and forget the other one, there's only two that the patents are expiring on, but for those two, are they all FDA designated as interchangeable?
None of them are, because they're not interchangeable biologics. I could be wrong. I believe there may be one that is going to be interchangeable, and I don't know. I wanted to say it was a Humira biosimilar, but I don't recall. I'd have to go hunt that down. But for the most part, none of the biosimilars that have been FDA approved yet have gone through the interchangeable pathway.
Okay, yeah, that's what I was getting, because I thought that the companies they have to separately apply, right? There's got to be a new application to support the interchangeability with the reference.
Correct. It's a slightly different process.
Okay. So in light of that, it seems like we probably are not in a good position to just open those doors on interchange. TIP.
You could under the therapeutic interchange. So like a pharmacist right now could not just automatically make the change. If if Humira comes in, we couldn't change to the adalimumab biosimilar without getting a new prescription. However, if you gave us direction that they are interchangeable, we could require that through therapeutic interchange.
Okay. So it sounds like they'd have to go to the prescribing physician to ask, or this committee could make that recommendation, or the FDA would put a label on it.
Correct.
And we might, this is just my opinion, I might be driving a little more than I should as chair right now, but unless the FDA were to say, we think this biosimilar is interchangeable with the reference product, or unless we were to have a more dedicated report from DUR on the biosimilars, I'm not sure I would feel comfortable making that motion, but I welcome other input from the committee.
So Kavita here, I guess my question is, there's with therapeutic interchange, to me, that's like two separate scenarios. One is the one that Donna, you described, where, interchanging Prilosec for Prevacid, which is basically omeprazole for pantoprazole, which is two different drugs within the same class. While here, I think what we're questioning is basically the brand name for the generic almost, right? So like the Prevacid for the pantoprazole, whether that is allowable, not one drug for another. And I don't know if there's a way to call that out, whether whenever there's a biosimilar available, that can be interchanged. Does that question make sense?
Yeah, and I'm looking at this is Donna again, from a regulatory standpoint, all of the biosimilars are individual, unique, different drugs than the biologic originator. The way that they go through their approval pathway, they're not considered interchangeable. So when I go there, I'm thinking that they are almost like two different drugs from a regulatory standpoint, but they have the same, underlying active ingredient. But when you look at them, they have the little 4-letter, suffix on there to say which company, to identify which company makes it. But I agree with you. It's, do we want to consider these like a traditional brand generic, where they're interchangeable? But there's also the question of, if we make them interchangeable, do we allow etanercept to be substituted for adalimumab when when it's for the same indication? So that's a second item that you would need to address.
Yeah, just to wrap up that thought, Kavita, here again, I certainly would be in favor of the first and not of the second scenario, right? Like brand versus generic, simplistically putting it, that makes sense. Interchange within the drug class because of the nuances of these conditions and the thorough review that we saw from DURP. The interchange within the drug class, I probably would not be in favor of.
This is Laura Bestie, just to confirm a point. So if a provider orders Humira, is that a preferred product? Because I know that these agents are going to require prior authorization, if I'm not mistaken. So at that point, just like when a provider would order omeprazole and pantoprazole is the preferred agent, they get a letter that tells them this is the preferred product. Does that piece play into this at all as far as biosimilars or not?
For Medicaid, I mean, this is where the Medicaid and the this is Donna again, Medicaid and the ERB programs kind of diverge in our preferred drug list. So for Medicaid, Humira is preferred at this time. And when the biosimilars come out, they are likely to be more expensive than Humira, net of rebate. And so I'm based on past biosimilars coming to market, we have made those biosimilars non-preferred because of that. However, for the ERB program, Uniform Medical Plan, it's the opposite, where the biosimilars are generally less expensive than the originator. And so they will make them preferred. The biosimilars are more likely to be preferred for our ERB program. So the prescriber would still have to write, if Humira came in, a prescription came in for Humira for our ERB program, it would reject and tell them which preferred products, products were preferred. And then the pharmacy would have to call and get, a new prescription for the biosimilar adalimumab. I also wonder, this is a question, like if the prescription just comes in saying adalimumab and not even, Humira. A question for the Pharmacy Quality Assurance Commission is, does the pharmacist get to select which biosimilar to dispense, or do they need to call the doctor and ask them for a preference? Because if they don't indicate that four-letter suffix, potentially you could pick any one of them.
Right, so Donna, that's where I'm a little bit confused. This is Peter again. So I would imagine that if a clinician wrote dispense as written, then the pharmacy would be required to either dispense the innovator product that's being requested, or to get a different prescription, right? And do we require a designation from this group of therapeutic interchangeability, or say when the pharmacy receives a prescription for Humira, but it's more financially sustainable to dispense Amjevita, which has comparable data and it's the exact same product, just kind of approved in a different way. Do we need to have that in the motion, or do you have everything you need on the back end to kind of dispense the more financially sustainable product?
I believe we need it in the motion because from a regulatory standpoint, these are different products. They're different drugs. They're not interchangeable.
So I would be in favor of declaring the infliximab and adalimumab products as therapeutically interchangeable. That's the data I'm most familiar with. And I would be fine putting it in the motion.
And so I would make sure that, this is Donna again, that we clarify that they're interchangeable with their innovator product.
Correct.
Yes. Or the original biologic. Reference biologic, I think is what they call it. They don't use the word innovator with the biologics.
Kavita here, I would add etanercept to that list too. As I understand that is also available and shown to be similar in efficacy.
This is Laura Bestie. Could you change it to these medications cannot be subject to therapeutic interchange except when there's an equivalent biosimilar available, rather than listing out specific product names?
Can you repeat the addition except when?
When there is an equivalent biosimilar available.
Okay, by throwing in the word equivalent, you're throwing a monkey chin. So I would say just a biosimilar.
Okay, I agree.
So I have a question for the committee. When we're making this addition, the last paragraph in the motion, is the intent there that we are advising HCA that in the classes where the biosimilar is available, go ahead and do therapeutic interchange? Or do you mean do therapeutic interchange if the FDA designates that biosimilar as interchangeable with the reference product?
So this
I
is-
would do the first. Yeah, the former.
Yeah.
So without the FDA designation, I'm comfortable calling the biosimilar therapeutically interchangeable.
Okay.
This is Donna. We wouldn't need this motion if they were interchangeable biosimilars. But Lita, I would like to suggest we say except biosimilars may be interchanged for its reference biologic if available. Maybe the if available goes after biosimilar, sorry. This is to make sure that it's clear we're not saying you can interchange. You can only, the interchange for biosimilars is only within its own drug biologic type, and not, because otherwise I think you could read that to say I could substitute a biosimilar for a drug that didn't have a biosimilar.
Beth, in your presentation, can you remind us what, if any, data was presented regarding biosimilars versus reference product?
We looked for information on the biosimilars, but we grouped them by that main ingredient, so we didn't separate them out.
Okay. I might be a little bit more risk averse than other committee members right now, but I'm just keeping in mind, biosimilars are highly similar to the reference, but they're not exactly similar. They might have some slight differences in efficacy and toxicity. And in the setting of the committee not having a definitive analysis, I'm just raising the question of, are we in a solid position to make this motion?
This is Christy Wyland. Alex, I'm similar to you in the sense that I am hearing different references of how people are describing biosimilars among the committee members. And so I'm wondering if we actually need to have a review of how we determine or how we think about biosimilars, because I'm hearing that some individuals are seeing it more as like a generic versus the FDA isn't necessarily regulating it that way. And so I don't disagree necessarily with this motion, but I feel like even within the committee members, it may be interpreted differently of what a biosimilar is.
Mm-hmm. Makes sense, yeah.
This
Here-
is Laura Bestie. Are the providers notified if that change were to be made? That's a question for Donna, probably.
Yeah, this is Donna. The therapeutic interchange does require the pharmacy to notify the prescriber of what was interchanged in its place of what was prescribed. So they would, I believe, if they dispense a biosimilar, I think the law states even if they were interchangeable, they have to notify the prescriber if they dispensed a biosimilar in its place.
Donna, do you know if, sorry, Dimitri has a question.
Well, I don't have a question as much as a comment, which is that you're not the only, I think, somewhat risk-averse person in the committee, and that I also kind of second the thought that it seems like we don't have the, at least we weren't presented with, I think, some of the relevant data calling out specific biosimilars and how they compare the referenced biologic in these outcomes of interest, which would help inform this kind of a decision. So I'm also a little bit uncomfortable with kind of with where things are as is.
Okay, I'm going to do my chair role thing right now and move us toward a consensus here. I think we have two very good thoughts, two different directions to go here. Donna, correct me if I'm wrong, biosimilar interchangeability is a designation from the federal level at FDA, but the states get to govern what they do with that. Is that right?
The interchangeable designation is provided at the FDA level, yes. Washington State has a law that allows us to do therapeutic interchange for drugs that are not therapeutic equivalents. So, it's not a brand generic interchange, it's a one drug to another. I believe this type of substitution falls under that because they're not designated interchangeable by the FDA. So in Washington State, we can make this designation for only prescriptions filled in Washington.
Got it. Okay, so the local dispensing and substitution is governed at the state level, which this committee has a role in advising.
Mm-hmm.
Do we know what other states have done? For instance, maybe member states that participate with DURP with regard to this? For instance, I mean, if it was the case that half of the states in the US locally decided that this type of interchange was okay on drugs that did not have the FDA interchange designation, then we might be in good company. But we might want to know that as a committee before we do this.
I'm not aware of any other state that has a similar law in place as our therapeutic interchange law.
Okay.
We're cowboys out here.
This is Peter again. I definitely agree with what's been said that the biosimilar therapeutic interchangeability it's a bigger step than like branded generic, but it's definitely a much smaller step than kind of an agent in one class to a different class. And if we were to approve therapeutic interchange, which by the way, I'm comfortable taking it out or leaving it in either way. But if we were to approve therapeutic interchange for the biosimilar products here, we would not be the only health plan in Washington State who has approved therapeutic interchange for biosimilars. The other P&T committee I'm on has declared therapeutic interchange for both infliximab and adalimumab products. But I will say that when we did approve that, we brought all the data and looked at it. So I'm comfortable leaving it in or taking it out. And if we take it out, I would recommend that we bring it back specifically for the purpose of looking at the therapeutic interchangeability and the comparative efficacy and safety data at a future meeting, because there can be a very significant difference in price. Now it gets into a lot of the contracts and things, and so some of the prices are actually inverted when it comes to this health plan. But I want to make sure that the health plan has the flexibility to use the most financially sustainable products that have equivalent data.
Thanks, Peter. I appreciate the procedural call out that you made that happened at your health plan in terms of you went ahead and allowed the interchange, but evidence was presented and deliberated by that committee, which we may not have gotten. The angle of the DUR report may not have been focused in this particular regard. So I think I'm hearing the committee say, we want to investigate this. We want to have the option for biosimilars out there. There is a price difference. There could be an efficacy level that's commensurate, but we'd like to have some more information presented to follow our procedure of reviewing data and then making motions on that. So then, committee, we have this last paragraph that's sitting before us on the motion. I'll entertain either a motion to keep it or to take it out and go for additional information, which we can request of HCA.
This is Laura Bestie. I would motion that we take that out for now and we request further information.
Does anybody, this is not a procedural motion, but I'm going to ask the committee, is anybody opposed to Laura's suggestion?
This Kavita here. I still feel like keeping it would be appropriate from a patient standpoint, because it's very limited to specific biosimilars for their own reference drug. But maybe there's a majority consensus that we can come to, and I'm happy to go with the majority.
Thank you, Kavita. Any other thoughts from the committee on removing the motion but bringing back additional information? Anybody not okay with that? Okay. And Kavita, your point is well taken, and I think this committee can definitely ask HCA to bring that information back so that your point is addressed on behalf of the patients that we're serving. So Donna, do we need to build that request into this motion? Or is that something we can just request verbally and expect to be done?
We'll have to go back and work with the DUR program to see, if we have the funding to do that level of research or another report. So we can just take that as a takeaway to do for, I won't commit to next meeting, but we'll have to figure that out with the DUR program.
Okay. And maybe if it's spendy or time consuming to do the big review, if we can do something along the lines of what Dr. Barquette was mentioning, if we could have some understanding of what's happening at other state levels in health plans, that could be helpful also. Okay, committee, we have the motion in front of us, which I think we've been very thoughtful about. And ready to entertain a motion or additional questions or comments. if you're nervous to make a motion because you don't want to say the names of the drugs, you can say the names of those drugs as you're doing the motion, if that's what's holding you back.
Okay, this is Laura Bestie. I move that after considering the evidence of safety, efficacy, effectiveness, and special populations for use of targeted immune modulators for FDA-approved indications relative to rheumatoid arthritis, ankylosing spondylitis, Crohn's disease, and ulcerative colitis, I move that the following medications are efficacious for their approved indications, including their applicable biosimilars when available. The PDL must include a drug approved for treatment of the following FDA indications: rheumatoid arthritis, ankylosing spondylitis, Crohn's disease, and ulcerative colitis. It must include a self-administered agent if indicated. These medications cannot be subject to therapeutic interchange in the Washington preferred drug list.
It's Christy Weiland, I second.
Thank you, Laura and Christy. All those in favor, please say aye.
Aye.
Any
Aye.
opposed?
Aye.
Okay, I thought you might oppose, Kavita, so I was waiting a beat there. Any abstentions? Okay, the motion passes. Thank you, committee. Thank you, everybody at HCA for your input, helping us through that one.
So
Complicated
Alex,
parts of-
and
yeah.
I think we're scheduled for a break. However, the DURP folks need to leave at 11:30. They were hoping that they could maybe try to get through their their final surveillance report quickly before we go to break.
That works for me. Does it work for the rest of the committee? All right, our bladders are strong. Let's move into atopic dermatitis. Whenever you're ready, is this Sneha or Andrea?
Hi, everyone. It's Andrea.
Andrea.
And should I get presenter rights, or can I go ahead and try to share my screen? I do have them.
Go ahead, yeah.
Let me try this. Okay. Are you seeing that?
Yes.
Okay,
Yep.
wonderful.
Go for it.
Okay, yes, thank you. So my name's Andrea Vintro, and I'll be walking you through the surveillance report for pharmaceutical treatments for atopic dermatitis. Oh, I see. Oh, there we go. So on this first slide, we have the overview, topic history for this topic in DURP. First, then a brief background on the clinical topic. Then we'll go into PICO's key questions and methods, followed by our findings, and then wrap it up with a summary for the surveillance. The table on this slide lists the prior deliverables on this topic from DURP with the most recent item at the top, but I'm going to start at the bottom. The first report there was completed, was a systematic review in 2017. Then in 2019, we completed a surveillance report where that volume of evidence was deemed substantial enough to commission that update of the systematic review. And that update was completed and presented in February of last year. And the search dates for that were from January 2017 through mid-August of 2021. And this is just a list of abbreviations in the presentation, and it's here for you as a reference. So briefly, atopic dermatitis, it's a chronic inflammatory skin disease characterized by intense itching and recurrent lesions that can have this pattern where you'll have periods of recovery or remission in between those flare-ups and relapses. The causes are multifactorial, but they can include environmental and genetic factors, as well as immunological components, and the result is this disruption of the structure and function of the epidermis, which is that outer layer of the skin. The condition affects about 7% of adults and about 10% of children in the US. The first line of treatment includes counseling to avoid triggering factors that may initiate or exacerbate symptoms, like avoiding certain soaps or detergents or other potential allergens. And then moisturizers and other topical anti-inflammatory therapies like corticosteroids, are also used initially. And then with more persistent cases, additional step-up therapies are often recommended, including phototherapy, topical calcineurin inhibitors like tacrolimus, or systemic treatments that are taken orally or subcutaneously via injection. So for this surveillance, our population of interest includes all adults and children. So that includes infants who are with moderate to severe atopic dermatitis. For the interventions on this slide, we start with the 8 FDA-approved non-steroid drugs, and those are listed in alphabetical order. So 3 of the drugs are Janus kinase inhibitors, or JAK inhibitors, as you see there. Both abrocitinib in the top row and upadacitinib in the bottom row are the most recently approved therapies in January of last year. They're both administered orally and are for the indication of moderate to severe atopic dermatitis. And just to note that all drugs for the moderate to severe indication are noted in bold. Ruxolitinib in that 5th row from the top is also a Janus kinase inhibitor, but it's administered topically. And this drug was approved in 2021 for the indication of the mild to moderate severity. The other 3 drugs that are topical medications include crisaborole, and then in the 4th row we have pimecrolimus, and then in the 6th row from the top, tacrolimus with that brand name Protopic. That was approved in 2000, and also for the indication of moderate to severe severity level. And then there are 2 drugs delivered subcutaneously, and those are dupilumab and tralokinumab, and both were approved for the indication of moderate to severe atopic dermatitis. So on this slide, we have the interventions of the 3 key pipeline therapies that we included. So we have baricitinib, which is a Janus kinase inhibitor. It's administered orally. And then we have lebrikizumab and nemolizumab, which are both interleukin-13 agonists, and those are delivered via injection. The other 4 therapies included here are commonly used for off-label atopic dermatitis, and those include azathioprine, cyclosporine, and mycophenolate, and all of those 3 are immunosuppressant drugs. And then we have omalizumab, which is a monoclonal antibody, and that's delivered via an injection. So for our comparators there on the left, we're interested in another included intervention, so any head-to-head trials, also topical corticosteroids, and then for pipeline therapies only, we would include standard of care or placebo. And then for outcomes there on the right, we have response to treatment, disease symptoms, quality of life, and then also adverse events, as well as serious adverse events. And then randomized controlled trials are the only study design that we've included in this surveillance. So for our key questions, we're asking about the comparative effectiveness and harms for the included therapies, and the general effectiveness and harms of the key pipeline therapies for atopic dermatitis. So that covers key questions 1 through 4. And then key question 5, we're asking about any ongoing studies for those interventions. So for our methods, we first searched for eligible trials using the drug names and other relevant keywords in the registries that are listed there in the light green boxes on the left. Then we searched for those trial identifier numbers in Ovid Medline and Google for any new publications of RCTs for the interventions. And then we also searched Google, the FDA, and IPD Analytics websites to identify any newly approved drugs and pipeline drugs. And then for any new formulations as well, indications and serious harms or warnings. And the timeline for these searches were since the search in the updated report. So that was from August of 2021 through early January of 2023. So on to our findings for this surveillance. So we identified 6 new RCTs for 5 of the 8 FDA-approved drugs for atopic dermatitis, and all of them except for 1 compared the intervention to placebo. So that 1 new head-to-head trial compares abrocitinib with dupilumab. And the 5 placebo-controlled trials were for abrocitinib, crisaborole, dupilumab, tralokinumab, and upadacitinib. So there was 1 new trial for each of those drugs. On this and the next slide, there's a little bit more detail about those newly published studies. So that head-to-head trial of abrocitinib and dupilumab is a multinational trial with over 700 adults, and those participants were followed for 26 weeks. In the second row, we see the JADE regimen trial, also an international trial that looked at 2 different doses of abrocitinib compared to placebo in nearly 800 individuals, and the randomization period for that trial was 52 weeks. And then the study of crisaborole versus placebo was conducted in 727 individuals in Japan for only 2 weeks. And all of those trials measured both effectiveness and safety outcomes. So on this slide, starting at the top, we have the newly published trial for dupilumab compared to placebo. And this was in adults from China, and the participants were followed for 28 weeks. In that second row, we have an RCT for tralokinumab compared to placebo in 277 adults with the indication of severe atopic dermatitis only. And then in the bottom row, we have the trial for upadacitinib or Rinvoq, which included about 270 adults from Japan. The participants were on 1 of 2 doses of upadacitinib or placebo, and then followed for 112 weeks. And all of those trials also measured both effectiveness and safety outcomes. So next we have ongoing studies. So for the FDA approved drugs, we identified 15 ongoing studies. And on this slide, we have the 3 head-to-head trials, ongoing trials. So the first study compares crisaborole with tacrolimus in youth in the US. And this trial is indicated as complete on clinicaltrials.gov and has some results posted there. The next trial compares dupilumab with cyclosporin as well as topical corticosteroids. And of course, cyclosporin is not FDA approved for atopic dermatitis, but sometimes used off-label, and it's included in our PICOS. The sample size estimation is 318 youth with an estimated completion date of 2024. And then that last ongoing head-to-head trial listed is of upadacitinib versus dupilumab. This is a multinational trial with an estimated sample size of 880 adolescents and adults, and it's expected to be completed in 2025. So this slide lists the remaining 12 ongoing slides for the FDA-approved therapies, which are either placebo-controlled trials or compare the drug to topical corticosteroids. And just for the sake of time, I'm not going to go into details about those. Other than that, we have 1 trial for abrocitinib, 4 for crisaborole, and one of those trials also includes topical corticosteroids as a comparator. We found 1 for dupilumab, 2 for ruxolitinib, 2 trials for tacrolimus, and both have topical corticosteroids as comparators. And then 2 trials of tralokinumab, 1 with placebo only, and the other is placebo and steroids as topical steroids as comparators. And to note on clinicaltrials.gov, 5 of these are marked as completed, and 3 are with at least some results that are posted there. We identified 11 ongoing RCTs for the 3 key pipeline drugs, and all are compared to placebo. So 3 of the trials are for baricitinib, 6 are for lebrikizumab, and 2 are for nemolizumab. And next we'll move on to any FDA actions. So there were no new drugs approved by the FDA for atopic dermatitis since the last update of that systematic review. But in this surveillance, we did list 17 additional pipeline therapies that were identified in the IPD Analytics website and that are currently in phase 3 trials. And those are in addition to the 3 key pipeline drugs that were moved forward from the prior report. And you can see that full list in the surveillance report. There were 2 new formulations since the last update, and those were 2 new doses approved. 1 was for dupilumab and 1 was for upadacitinib. We identified 1 new indication since the last report. So in June of 2022, the FDA expanded the approval of dupilumab to pediatric patients. And the expansion includes children 6 months to 5 years of age with moderate to severe atopic dermatitis. And then 1 new serious boxed warning was identified. So now the labels for all Janus kinase inhibitors warn that a recent study demonstrated an increased rate of all-cause mortality with this class of drugs, including sudden cardiovascular death. So in summary, we found 6 new RCTs for the FDA-approved drugs only. So no new trials for the key pipeline drugs or the drugs used off-label. 1 was a head-to-head trial of abrocitinib and dupilumab, and 5 were placebo-controlled trials for 5 of the 8 approved drugs. And then we found 25 ongoing studies. 15 of those were for FDA-approved drugs. 4 of those have results posted on clinicaltrials.gov. And then 11 ongoing trials were identified for the 3 key pipeline drugs. So summarizing FDA actions, there were no new approved drugs. There are now 17 pipeline drugs in phase 3 trials. This was according to the IPD Analytics website at that time. There were 2 new doses approved for dupilumab and upadacitinib, 1 new indication identified for dupilumab, and then that 1 new serious boxed warning for all Janus kinase inhibitors. So that is the end of this presentation. Thanks for your attention.
Thank you very much, Andrea. Questions for Andrea from the committee? Okay, hearing none, I think we have at least one. So we have 2 stakeholders. So we'd love to hear from our stakeholders at this time. Let's see. We have Valerie from Leo Pharma.
Hi, Dr. Park, can you hear me okay?
Yes, I can hear you. Please introduce yourself and tell us who you represent and if you have any conflicts of interest, and your time will start.
Sounds good. Well, good morning, everyone. I'm Valerie Ng, Medical Outcomes Liaison at Leo Pharma. Grateful to have this opportunity to share with you information on Adbry. So Adbry, or tralokinumab, is a first-in-class, fully human, high-affinity monoclonal antibody that specifically neutralizes interleukin or IL-13. IL-13 has been shown to be a key cytokine driving inflammation in atopic dermatitis or AD skin. Adbry, as you heard earlier, is indicated for the treatment of moderate to severe AD in adult patients whose disease is not adequately controlled with topical prescription therapies, or when these therapies are not advisable. The recommended dosage is an initial dose of 600 milligrams via subcutaneous injection, followed by 300 milligrams every other week. A dosage of 300 milligrams every 4 weeks or monthly dosing may be considered for patients below 100 kilograms who achieve clear or almost clear skin after 16 weeks of treatment. Efficacy was assessed in over 1,900 adult patients in the 3 pivotal trials where Adbry demonstrated superiority over placebo for primary and secondary endpoints of IJ01, EZ75, and worst daily pruritus or itch score at week 16, and maintained these responses at week 32 and week 52. The safety and efficacy profile of Adbry has been established in these pivotal extra clinical program, along with real-world case series, which are now available. And a long-term extension trial to evaluate the safety and efficacy of tralokinumab in patients who participated in previous trials is currently ongoing, with interim data available for up to 3.5 years. Most common adverse reactions were upper respiratory tract infections, conjunctivitis, injection site reactions, and eosinophilia. Most, however, were non-serious and mild or moderate in severity. Overall frequency of these adverse events was comparable across treatment groups and did not increase during prolonged treatment of up to 52 weeks. Overall, Adbry represents another option in the treatment paradigm for moderate to severe AD in adult patients. And with this option to provide a maintenance dosing of every 4 weeks for eligible patients, their chronic disease may be managed with fewer doses without the need for laboratory monitoring. Therefore, we'd like to ask the committee to consider adding Adbry or tralokinumab to the PDL as a preferred product for adult patients suffering from moderate to severe atopic dermatitis who had an inadequate response to topical prescription therapies. Thank you all very much for your time, and I'd be happy to answer any questions you may have.
Thank you, Valerie. Questions from the committee? Okay, hearing none, thank you. And turning back to Erin from AbbVie.
Great, thank you. Hello again, my name is Erin Novak, Medical Outcome Science Liaison with Medical Affairs at AbbVie. Thank you for allowing me another few minutes to provide information on upadacitinib or Rinvoq. My focus right now is on atopic dermatitis, where upadacitinib has been FDA approved to treat patients 12 years of age and older with refractory, moderate to severe atopic dermatitis, whose disease is not adequately controlled with other systemic drug products, including biologics or when those therapies are inadvisable. The dose is 15 milligrams orally once daily, or if inadequate response is occurring, 30 milligrams may be considered. Providers and patients with AD are looking for a quick reduction in itch and pain, along with lessening of inflammation, redness, and thickening of the skin. Patients can seek urgent medical care due to these complications, which drive healthcare costs. And upadacitinib can offer patients another treatment option. In 3 16-week placebo-controlled phase 3 clinical trials, upadacitinib met all primary and ranked secondary clinical endpoints. Measure Up 1 and Measure Up 2 looked at upadacitinib as monotherapy, and Add Up was a trial that evaluated upadacitinib in combination with topical corticosteroids. In these studies, there was a rapid onset of action. A significant reduction in itch was seen as early as 2 days after the first dose of upadacitinib 15 milligrams. And approximately 2/3 of patients saw a statistically significant 75% improvement in skin symptoms after 16 weeks. In all 3 studies, upadacitinib achieved disease control and statistical significance in the higher clinical thresholds of Eczema Area Severity Index of 90 and 100% skin improvement, and investigators' global assessment of 0 or 1. Upadacitinib safety is well studied, and the latest integrated safety analysis includes over 6,900 patients with over 15,000 patient years of exposure across 4 indications. The overall safety profile is consistent for upadacitinib across all indications, and the benefits and potential risks should be considered with all immunomodulators. Please see the prescribing information at rxabbvie.com for safety information, including boxed warnings and other warnings and precautions. AD is a heterogeneous systemic inflammatory skin disease that warrants flexible treatment options to provide clinically appropriate and accessible cure for the moderate to severe AD population. Thus, I want to close by respectfully asking that upadacitinib or Rinvoq be added to the state preferred drug list for all indications, including atopic dermatitis. Thank you for your time and consideration, and I'd be happy to answer any questions you have at this time.
Thanks again, Erin. Committee, any questions for Erin? Okay, hearing none. Thank you. Okay, can we turn our attention to the motion, Lita?
Yeah, and just for the record, I don't see any other hands raised.
Thank you. So our business, Lita, are we just approving the surveillance as adequate?
Right, first, if you approve, and then you can make a motion.
Sorry to clarify, is there one motion to accept the surveillance and there's a second to
Yeah.
Okay.
Yeah.
Got it. All right, committee, we'll entertain a motion if you feel the surveillance was adequate.
This is Peter Barkat. I'll make a motion that the surveillance report was adequate for the purpose of making a further motion on this drug class.
Thank you.
This is Kavita, I second the motion.
All those in favor, please say aye.
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 Any opposed or abstentions? And the motion passes. Okay, let's turn our attention to the motion now. Lita, I'd say we're close to being able to reiterate the prior motion, except the list of drugs that was included in the surveillance doesn't exactly match.
And Luke, can you tell me if I'm wrong that these grayed out drugs are still going to remain on the Washington PDL, even though they weren't reviewed?
This is Luke. Yeah, that's correct. Because they were reviewed previously, correct?
Yes.
Yes, we had a systematic review update last year in February. So actually, we could just reiterate the motion if the committee is so inclined. Dr. Barkett.
Sorry to drone on about this, but the therapeutic interchange. So I noticed that calcineurin inhibitors are called out in here for therapeutic interchangeability, but other classes where we have multiple agents, for instance, the JAK inhibitors are not. And I was just curious because I'm newer to the committee, how that had come about and what the process had been at the time that the calcineurin inhibitors were deemed therapeutically interchangeable.
Donna or anybody else from HCA? Would you like to comment on that?
This is Donna. I'm not sure if I recall of what the conversation was back in when they decided that these could be interchangeable.
Do you feel, Dr. Barkett, that there's information that was presented to us in other classes? I mean, whether it's the JAKs or the, I guess it'd only be the JAK inhibitors that have multiple things in there that we could call upon from this review that you would be wanting to see for therapeutic interchange?
I mean, I think whatever the process for therapeutic interchange would be. I mean, I guess this is a little bit different than biosimilars, where it's the same product but manufactured in a different way that might have kind of quality implications as opposed to medications in the same class that aren't exactly the same product. But I mean, I'm totally comfortable with the JAK inhibitors being declared therapeutically interchangeable, but I think that's a little bit of a bigger leap than, say, the biosimilar agents with the originator product. So I don't know that I would call that out in this motion, but it may make sense to have a process for looking at that at a future meeting as we get more medications in the same classes, and the difference in cost between those medications can be quite significant. It would be reasonable to look at therapeutic interchange.
Thank you. Noted. John McKay.
I'm just wondering if maybe or possibly the calcineurin inhibitors were interchanged due to their being topical in formulation or availability. If that might be one of the reasons.
Yeah, it's possible. I'm looking at the people who made the motion. Ginny, you seconded the motion back then. Susan's no longer with us, but I think John might be right. It may have had to do with the overall similarity of all those drugs, the Elidel and the Protopics and all of those they're so similar that the committee may have felt that was a reasonable move.
Yeah, I think it's probably outside of our scope today to declare it therapeutically interchangeable, but I would recommend at some point that we take a look at that with some dedicated data or time on a future meetings agenda. But I'm comfortable with the motion as it appears on the screen.
Folks from DURP and HCA, would you be able to respond to Dr. Barkett's thoughts about when the committee would expect?
So this is Donna. What I don't know what the ask is at this point in time.
I think the idea would be if there is evidence to support making a decision on therapeutic interchangeability of the JAK inhibitors, to bring that at a later date. And do you think that would be feasible to work into a future report?
Okay, so it sounds like this was a surveillance report. Am I correct?
Yeah, that's right.
So it sounds as if you are requesting an updated report that would include any head-to-head trials of the JAK inhibitors for atopic dermatitis. I can check to see if this class is being updated or not. I don't recall. Again, that would, if it's not on the list to be updated anytime soon, then that would be a separate report that we'd have to commission with DURP, and it would require us scoping it out, seeing if we have the funding to support it, and getting it in the queue with all the other work that DURP is doing.
Well, in that case, I'd say that there isn't a rush on this, but if it could be worked into a future report, it would be appreciated. But otherwise, I don't think we need to make a separate request or commission.
Okay. And to be honest with you, therapeutic interchange rarely happens the way it's supposed to, the way it was originally designed, because of the rules around, from the individual pharmacies themselves don't allow it. So like a Walgreens, CVS, they're, from a safety concern, a risk liability concern, they don't let their pharmacists do this anyway. So I don't think you're impacting anything. And Dr. Barkett, you might be more from, at Kaiser, if you have your in-house pharmacies, your pharmacists are doing it automatically because it's almost like a standing order. Whereas out in the retail community pharmacies, they don't have that same level of oversight from, a staff model HMO.
That makes sense.
Okay, other questions or thoughts?
This is Laura Bestie. Can we just fix the spelling of calcineurin to be RIN on the end? Thank you.
Great call out, Laura. Okay, we will entertain a motion. Or do I see, Dr. Barkett, you still have your hand raised. Did you have another thought?
Oh, no, just that's residual. Sorry about that.
Okay. Thanks.
And I can make the motion. So this is Peter Barkett making a motion that after considering the evidence of safety, efficacy, and special populations for the treatment of atopic dermatitis, I move that abrocitinib, azathioprine, crisaborole, cyclosporin, dupilumab, mycophenolate, omalizumab, pimecrolimus, ruxolitinib, tacrolimus, tralokinumab, and ipetacitinib are safe and efficacious for the treatment of their approved indications. The calcineurin inhibitors can be subject to therapeutic interchange in the Washington preferred drug list.
This is Dmitry Davidov, I second.
Thank you. All those in favor, please say aye.
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 Okay, any opposed or abstentions? And the motion passes. Lita, I'm wondering if now is a good time to take a slightly early lunch and then hit the DUR board when we get back.
Absolutely.
Okay.
So why don't we come back at 12:30?
Sounds good.
Good.
See you all after lunch.
Thank you.
Hi, Lita.
Hi. So if the committee can turn back on their cameras so we know you're all here to begin. Thank you. And Umang, are you here?
I am, yes.
Okay. All right, Alex, take it away.
All right, welcome back, everybody. Hope you had a great break. The P&D committee is adjourned now. We're going to convene our DUR board. And first order of business is Umang Patel with Magellan to start us off with the ADHD anti-narcolepsy class. Whenever you're ready, Umang.
Perfect. I'm just waiting for the screen to share.
Hi, this is Marissa.
Alrighty.
I just wanted to note for the DUR board, there has been a schedule change as far as we will not be reviewing the anti-narcolepsy policy at the very end. Unfortunately, Ryan T is unable to present this afternoon, so we'll be pushing that policy to the August meeting. So I just wanted to note that change. So really for the DUR board meeting today, we will just be reviewing classes specifically for the AHPDL. So I just want to be transparent about that. And then Umang, I should be displaying the slides. Can you see them okay?
I can.
Okay, perfect. And it's all ready for you to go.
Awesome. Thank you, everyone. So I'm Umang Patel with Magellan. We will be reviewing the for the Washington Drug Utilization Review Board meeting. If you can go 2 slides. The first class here we have will be stimulants and related agents. Just to remind the committee and some of the attendees, Magellan has certain classes that aren't always on a one-to-one level with Apple Health PDL. For example, we have an umbrella term for stimulants and related agents. Apple Health PDL does kind of break it down based on specific mechanism of action or alternative pathways. So I will do my best to clarify that, but if there are any questions from any committee members, please let me know. So this first class will have our stimulants and related agents, and this encompasses for the ADHD anti-narcolepsy has dopamine and norepinephrine reuptake inhibitors, histamine 3 receptor antagonist, inverse agonist, non-stimulants, stimulants long-acting, stimulants short-acting, and miscellaneous. Moving right along to the next slide. If there are, what we do here is we do review any significant clinical updates or changes that have happened in the last roughly 1 year. If there are not any changes, I pass it right back to Dr. Park and the committee. If there are, I will give a little bit of a brief background for the relevant disease states that were affected by the update, and we'll move forward. So the first we have here, ADHD or attention deficit hyperactivity disorder. The most common use of stimulants is for the treatment of ADHD, for which they are considered first-line therapy. It has been diagnosed in approximately almost 10% of children 3 to 17 years of age, and about 4% of adults in a chronic condition with core symptoms of inattention, hyperactivity, and difficulty controlling behavior. It may also be accompanied by internalized disorders such as sadness and anxiety, as well as aggressive and oppositional disorders. And there are 3 main types of ADHD. There's primary hyperactive, primary inattentive, and mixed. According to the medical letter in 2020, it suggests that school-age children, adolescents, and adults begin with an oral stimulant, noting that none of the agents have shown to be more effective than another. However, some patients may respond better to amphetamines than to methylphenidate, and vice versa. They advise that use of long-acting formulations, which generally contain both immediate and extended release components, has become standard clinical practice, and the addition of a short-acting stimulant may improve symptom control early in the morning or to prolong the duration of action in the afternoon. While the alpha-2 agonist clonidine and guanfacine and the selective norepinephrine reuptake inhibitor such as atomoxetine can reduce ADHD symptoms, these agents are considered less effective than stimulants. And the use of pitolisant and solriamfetol were not addressed drugs for ADHD. Moving right along to drug-specific updates, here we have Avecchio ODT. So in October of last year, the labeling was revised to change the indication for the treatment of ADHD in pediatric patients 3 to 17 years of age to now include only patients 6 to 17 years of age. So the indication pool actually contracted, did not expand. And the 2.5 milligram strength was previously indicated as a starting dose in patients 3 to 5 years of age. Labeling has been updated to remove all information related to the 2.5 milligram strength. The 5, 10, 15, and 20 milligram ODTs remain available and are indicated for use in patients now 6 to 17 years of age. Just a quick reminder for the committee, there can be a lot of information here when I go through drug-specific information. I try to bold the relevant updates. So here you can see there was a change in indications and availability formulations here. On the next slide here, we have a few drug shortages and drug-specific updates. First was with amphetamine mixed salts, Adderall. In October of last year, the FDA released shortage information for immediate release amphetamine mixed salts, as Teva was experiencing ongoing intermittent manufacturing delays. And in May of this year, FDA updated its shortage information for amphetamine aspartate, amphetamine sulfate, dextroamphetamine saccharate, and dextroamphetamine sulfate. Several manufacturers have product unavailable with supply constraints or on allocation. Teva has brand Adderall tablets available and limited supply for generic product. And then lastly, in March of this year for Disoxin, both manufacturers of generic methamphetamine are reporting that the product is currently unavailable. Estimated resolution is by Maine in September 2023, and brand Disoxin still remains available. And that's all we have for that class, so I will pause there for the committee.
Thank you, Umang. Any questions, committee, for Umang? Okay, hearing none, we have at least one stakeholder for this section. On my list is Gregory. The agenda says Gregory Park. The COI forum says Gregory Parks. I'm not sure which it is, from Axome. Oh, I'm sorry. Hold on. Gregory, Marissa needs to show us the PDL first.
Hi, this is Marissa. No problem, Alex. I will try to go through this pretty quickly. I did want to note for the ADHD class, there is an error. We do have the histamine H3 receptor antagonist drug class listed there, but actually as of April 1st, that class actually no longer exists. That class used to hold the product Wakix, which now actually got moved to our ADHD non-stimulants class. So there is really today only 5 AHPDL drug classes that you will be really making a motion on. So just wanted to call that out, that we did recently make that change of moving that product. So I'll go through kind of drug class by drug class for ADHD specifically. So for our dopamine and norepinephrine reuptake inhibitors, or DNRIs, we just have Sunosi in that class, and that product is non-preferred. Moving on to our non-stimulants, you'll see here we have atomoxetine, clonidine, guanfacine, Quellbri, and it looks like those are the only preferred products in that class. And like I mentioned, we did move Wakix to the non-stimulants class, so you'll see it does live here now, if you were wondering. Moving on to our stimulants long-acting drug class, we have lots and lots of preferred products here. We have brand name Adderall XR, we have the generic amphetamine dextroamphetamine, brand name Concerta, generic dexmethylphenidate in different formulations. We have methylphenidate, as well as different methylphenidate formulations as well. You see the generic ERs here. And one other call out is brand name Vyvanse. Those are the preferred products in that class. And then moving on to our stimulants and miscellaneous drug class, we have here preferred armodafinil, which is generic. We have generic modafinil, and it looks like those are the only preferreds. And then moving on, lastly, to our stimulant short-acting drug class, we do have generic amphetamine dextroamphetamine, dexmethylphenidate generic, brand name Focalin, brand name Methylin, generic methylphenidate of different formulations, and it looks like that is it. and I can take any questions from the DUR board regarding the AHPDL.
Thank you, Marissa. DUR board, any questions for Marissa? Okay, hearing none. Now let's move to our stakeholder. Gregory, are you with us?
Yes, I'm here. I did have a question. SNOC is indicated for narcolepsy and obstructive sleep apnea. And did I hear that the narcolepsy review is occurring at a later date, or is that would this be the appropriate time to speak about it?
The policy for narcolepsy is being reviewed at a later date. But the medications are being reviewed under this particular topic.
Okay, great. I'll go ahead now. Thank you for the clarification.
Thank you. Yeah, go ahead and introduce yourself, who you represent, any conflict of interest, and your 3 minutes will start.
Of course, I'm Gregory Parks. I work at Axome Therapeutics. Axome makes Sunosi solriamfetol, and that is my only conflict of interest. Thank you for the opportunity to provide information about Sunosi today. My name is Gregory Parks. I'm Executive Director of Medical Affairs at Axome Therapeutics. I'm here today to request that Sunosi be placed in the preferred position, reducing the step edits in place to allow physicians the ability to exercise their clinical judgment for appropriate patients. Sunosi is indicated for the treatment of excessive daytime sleepiness, EDS, associated with narcolepsy or obstructive sleep apnea. Sunosi is not indicated to treat the underlying airway obstruction and sleep apnea, and primary therapy should be continued with Sunosi. Sunosi's effects are thought to be mediated through its function as a selective dopamine and norepinephrine reuptake inhibitor. Sunosi is a Schedule IV medication defined by the DEA as having a low potential for abuse and dependence, and it is a wake-promoting agent, not a stimulant. Sunosi was approved based on 4 placebo-controlled phase 3 clinical studies of patients with EDS due to narcolepsy or OSA. In all studies, Sunosi resulted in robust improvements in objective measures of wakefulness as early as week 1, and maintained through week 12, with improved wakefulness lasting through 9 hours post-dose at week 12. Sunosi improved patient-reported sleepiness within 1 week of initiating treatment, and these improvements were maintained through 1 year in an open-label safety and maintenance of efficacy study. In this study, over 70% of OSA patients achieved normative levels of sleepiness at week 12. In these studies, 78 to 90% of participants with narcolepsy or OSA reported improvements in their overall condition at week 12. And these improvements were maintained at 1 year. Similar results were found for clinicians' assessment of overall condition. And additionally, in a phase 4 study, Sunosi demonstrated significant improvements in cognitive function in patients with EDS due to OSA. The most common adverse events reported with Sunosi and 12-week clinical studies in OSA and narcolepsy were headache, nausea, decreased appetite, anxiety, and insomnia. Sunosi is associated with small dose-dependent increases in blood pressure and heart rate. The use of MAOIs is contraindicated, and please consult the Sunosi prescribing information for additional safety information. While no head-to-head studies have been conducted, an independent meta-analysis of 14 clinical trials recently concluded that Sunosi, armodafinil, and pitolisant all reduced daytime sleepiness for patients with sleep apnea, with Sunosi having superior effectiveness. Additionally, recent guidelines from the American Academy of Sleep Medicine contain a strong recommendation for the use of solriamfetol in treating narcolepsy. In summary, Sunosi exhibits robust, long-lasting improvements in wakefulness and has a well-established safety profile. We request respectfully that Sunosi be placed in the preferred position and that step therapy be reduced so physicians are able to exercise their clinical judgment for appropriate patients. Thank you.
Thank you very much, Gregory. Any questions from the DUR board for Gregory? Okay, hearing none. Lita, are there any other stakeholders that have popped in for this topic?
I do not see any other hands raised.
Okay, so let's turn our attention to the motion. If all the committee members could come on camera and let's look at this motion.
This is Kavita Chawla. I move that all products in the drug classes listed on slide 2 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Dmitry Davidov, I second motion.
Thank you. All those in favor, please say aye.
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 And any opposed or abstentions? Hearing none, the motion passes. Thank you. Okay, back to you, Umang, for the allergy section.
Perfect. The next we'll have are the anti-allergens, the oral medications. And in the Apple Health PDL, these encompass the allergenic extracts or biologics. So going on to the next slide here, a little bit of background. So allergic rhinitis or hay fever is with or without allergic conjunctivitis, affects approximately 8% of adults, 9% of children in the US. Allergen avoidance and medication therapy can provide significant symptom relief, but for many symptoms do remain. For some of these patients, allergen immunotherapy is a reasonable alternative. Subcutaneous immunotherapy, SCIT, has been proven to be effective in the management of allergic rhinitis and asthma since the early 20th century. However, it requires regular injections, typically over a period of 3 to 5 years, carries the potential of a serious symptomatic allergic reaction in response to the treatment itself. Secondly, for peanuts, peanut allergies in 2010, an electronic survey of US homes estimated that about 8% of children have food allergies. Estimated that peanut allergies specifically affect almost 1 million children in the US, and only 20% will outgrow their allergy. Previously, food allergy treatments primarily consisted of avoiding the allergen and promptly treating any accidental exposures. Reactions to peanut exposure varies from mild skin and/or GI symptoms to severe angioedema and anaphylaxis. When accidental peanut exposure occurs, antihistamines can manage mild to moderate reactions, but patients must carry an epinephrine autoinjector to treat severe reactions. In January 2020, the FDA approved the first treatment for oral immunotherapy, Palforzia, and it involves feeding an increased amount of an allergen to a person allergic to that particular allergen. It does not cure food allergy, rather it induces a level of tolerance that prevents allergic reactions. Though it is an OIT agent, it has many similarities to the SLIT products in regard to safety, tolerability, and administration issues. And current guidelines on peanut allergy management from key stakeholder groups have not been updated yet to include this new medication. So moving right along to drug-specific updates, here we have house dust mite. As you can imagine, since a lot of these have the allergen within itself, but the names are extremely long, I won't fumble my way through that for the committee's sake. But in February 2023, the FDA approved expanded indication for use as immunotherapy for house dust mite induced allergic rhinitis with or without conjunctivitis, confirmed by an in vitro testing of IgE antibodies or skin testing to include adolescents 12 to 17 years of age. Previously, the indication included only adults 18 to 65 years. So indication did expand to include pediatrics 12 years or older. No changes to warnings and precautions. There is a black box warning for these, which, as mentioned earlier, can cause anaphylaxis, which can be life-threatening. Dosage, availability, all remain the same here. And then that's it. It's a quick class review, so I'll pause there for the committee.
Thanks, Umang. Any questions from the DUR board for Umang? Laura? Or no, you're just coming on camera getting ready for the motion. Okay. All right. Lita, any stakeholders on this one?
Yes,
Oh.
we have quite a few. But I'll let Marissa first show you the PDL.
I'm sorry, Marissa. I'm constantly skipping over you to get to the stakeholders. I need to stop doing that.
No,
Go
no
for it.
worries. I'll fit in somewhere. This class is not very exciting, actually, so it'll go pretty quickly. This is our allergenic extracts biologicals oral, and as you can see, we have pretty much all the products that live in that class as preferred. So not much there, pretty quick. And I'll hand it back to you, Alex, if anyone has any questions, or move on to stakeholders.
Thanks, Marissa. Questions for Marissa? Okay.
Alex, I actually made a mistake. I was looking at the antipsychotics stakeholders. So we do not have anyone signed up for allergies, and I do not see any hands raised.
All right, let's move straight into the motion. Okay, DUR board, we will entertain a motion on this allergenic extracts section.
This is Kavita Chawla. I move that all products in the allergenic extracts, biologicals, oral class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior auth to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second the motion.
Thank you. All those in favor, please say aye.
Aye.
And any opposed or abstentions? Okay, the motion passes. Let's see. We are almost caught up on time. Well, not really, but as close as we're going to get. Umang, you want to jump into antipsychotics, anti-manic agents?
You got it, Dr. Park, and I'll try to I'll shave some of that gap off, so we'll catch up. Next will be antipsychotics, and so as you can imagine, there are a lot of subclasses that fall under here. First one being, second generation antipsychotics, combinations, and specifically Parkinson's psychotic disorder treatment medication. So there is a little bit of background here, as one can imagine. So on the first slide here, schizophrenia is the most common psychotic illness. It affects about 1% of the population. Between 25 to 50% of schizophrenic patients attempt suicide, and 10% of patients succeed in their attempt. Symptoms can include delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms, and at least one of these should be delusions, hallucinations, or disorganized speech. Again, I should have mentioned this earlier to the committee. If there are no recent guideline updates in the last year or so, I either keep it here for completeness sake or I put it in the appendices for your reference. The American Academy of Child and Adolescent Psychiatry did create a guideline parameter, but that was about 10 years ago now. And so since it's no more than 5 years, since it is over 5 years old, this is considered historical. And so this is just here for the committee's reference. I won't go over them in detail. On the next slide here, American Psychiatric Association in 2020. Since schizophrenia is a chronic illness that afflicts all aspects of life, the goal of treatment was to stabilize the patient, defined as reducing acute symptoms to return to baseline functioning, prevent recurrence of symptoms, and maximize functioning of quality of life. Goals may also be based on individual patient preferences impacting school, employment, and other quality of life impacting components. Guidelines recommend that patients with schizophrenia be treated with an antipsychotic, including monitoring for both safety and efficacy. An antipsychotic should be continued in patients whose symptoms improve, while the guidelines suggest that the same antipsychotic be used. They recommend clozapine specifically be used in patients with treatment-resistant schizophrenia and in patients with a significant risk of suicide. They also suggest clozapine for patients with aggressive behavior despite other treatments, and a long-acting injectable is suggested for patients who prefer this therapy or for patients with a history of uncertain or poor adherence. Notably, the guidelines state that an evidence-based ranking or algorithm approach for antipsychotic selection is not practical due to the clinical trial heterogeneity and limited comparative trials. In addition, there is no preference for first-generation antipsychotics or second-generation antipsychotics. However, clinically meaningful distinctions such as tolerability do occur. With the exception of clozapine, no antipsychotic has demonstrated superior efficacy when compared to other agents within that same class. They also state that there is no reliable strategy to predict response. Thus, initial treatment should be individualized and include several patient-specific factors. And the guidelines also detail management of adverse effects such as acute dystonia, Parkinsonism, akathisia, and tardive dyskinesia, some of which may warrant a switch to alternative antipsychotic treatment. On the next slide, we'll pivot over to bipolar disorder. Lifelong prevalence here estimates the bipolar disorder ranges from about 0.9 to 2% of the population, characterized by mania, depression, or a mixed state. Criterion used to diagnose bipolar 1 disorder is the presence of a manic episode or a mixed feature specifier, and 3 or more other characteristic symptoms. These symptoms can include, there's a whole litany here, inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or pressured speech, flight of ideas or feelings of racing thoughts, distractibility, increase in goal-directed activity or psychomotor agitation, and excessive involvement in risky, pleasurable activities. Again, we have the American Psychiatric Association guidelines here, which are 21 years old, so I'm going to just leave it there. No need to go over those. And on the next slide here, for the, apologize, Marissa, if you can go forward 2 slides, it will go straight to FDA communications. There we go. Okay. One more. There we go. So in terms of FDA communications, there were some drug-specific updates. First, clozapine, which is generic for Clozaril or Versacloz. In November of last year, the FDA is temporarily exercising enforcement discretion with respect to certain clozapine REMS program requirements to ensure continuity of care for patients taking clozapine. FDA does not intend to object if pharmacists dispense clozapine without a REMS dispense authorization. And the second we have here is for paliperidone Invega. In February 2023, Janssen will discontinue manufacturing Invega 1.5 milligram tablets. Generic versions are still available of 3, 6, and 9 milligram tablets. On the next slide here, perfect. And so here we have Vraylar. So in December of last year, the FDA approved a new indication for the adjunctive therapy to antidepressants for treatment of major depressive disorder in adults as well. And I understand this is, there, as the committee can imagine, there's a lot of overlap between antipsychotics and antidepressants. And so I am reviewing that, but I apologize if there's a clear distinction for the Apple Health PDL. As you can see, it does have other indications that are not affected at all. No changes to warnings here either. The only update is for the dosage for that new indication, as you can see bolded at the bottom, where it is 1.5 milligrams daily with a recommended dose of 1.5 to 3 milligrams daily. And the availability is extended release injectable suspension here as well. On the next slide here, we have Rakindo. For here, the January of this year, the FDA approved a new formulation for the atypical antipsychotic as an ER injectable suspension for IM use. The product is indicated for the treatment of schizophrenia in adults and as monotherapy or adjunctive therapy to lithium or valproate for maintenance treatment of bipolar 1 disorder in adults. And so again, just a new formulation here. Nothing changes in terms of indications, warnings, or dosage here either. Righty. In April of this year, the FDA approved risperidone extended release under the name of Uzedy for the treatment of schizophrenia in adults. It was available as 50 milligrams per 0.14 mils, 75 milligrams per 0.21 mils, 100 milligrams per 0.28, 125 per 0.35, 150 per 0.42, 200 per 0.56, and 250 per 0.7, all in single dose prefilled syringes. As you can see, it does contain some warnings here that are that can be kind of seen across the antipsychotics. First being black box warning. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. It is not approved for the treatment of patients with dementia-related psychosis. Next, we have cerebral adverse reactions in elderly patients with dementia-related psychosis. And lastly, pregnancy. It may cause extrapyramidal symptoms and or withdrawals in neonates with 3rd trimester exposure. As you can see, the dosing here is initiated. The dosing depends on the risperidone immediate release dosing that is used on the patient. And so the prior oral risperidone therapy of 2, 3, 4, 5 milligrams is equated to the Uzedy 50, 75, 100, and 125 milligram once monthly dosing. Or once every 2 months dosing here. As I went through the litany of the availability, I won't go through that again there. Next, in April of this year, aripiprazole extended release injectable suspension was approved for the treatment of schizophrenia in adults and as maintenance monotherapy for treatment of bipolar 1 disorder in adults. The product will be available as 720 mg per 2.4 milliliters and 960 mg per 3.2 milliliters single dose prefilled syringes for IM use by a healthcare practitioner. Again, as you can imagine, the warnings very similar to the previous slide. Black box warning for elderly patients with dementia-related psychosis, cerebrovascular adverse reactions in elderly patients with dementia-related psychosis, and pregnancy. In terms of dosing, for patients naive to aripiprazole, established tolerability with oral aripiprazole prior to initiating treatment. The recommended dosage is 960 mg once every 2 months as a single injection, and it can be reduced to 720 milligrams in patients with adverse reactions. And then the last slide for this class, we have Rexulti. In May of this year, the FDA approved a new indication for the treatment of agitation associated with dementia due to Alzheimer's disease. The new indication carries a limitation for use stating it is not indicated as a needed treatment for agitation associated with dementia due to Alzheimer's disease. So just again, it is not indicated as an as-needed PRN treatment. No changes to anything else for Rexulti. The other indications remain the same. Warnings, very similar. For this new indication, for the dosage, starting dose is 0.5 milligram per day. Recommended target dose of 2 milligrams per day with a maximum of 3 milligrams per day. And the availability are in various strength tablets, 0.25, 5, 1, 2, 3, and 4 milligrams. I'm going to pause right there for the committee, as that is the end of the antipsychotics.
Okay, thank you, Umang. Questions for Umang from anybody on the DUR board? Okay. Marissa, over to you.
This is Marissa. So I have the AHPDL pulled up, so I'll go through it drug class by drug class. So the first antipsychotic drug class that I'll be going through is the second generation antipsychotics. We have quite a bit of preferred products in this class, so I'll try to hopefully point them out accurately as there's a lot of lines. So we have Abilify Maintena, which is preferred, generic aripiprazole tablets, Aristata, this will help, clozapine tablets, Geodon solution. We have various Invegas as far as the suspensions, which I believe is the injectables. Those are preferred. We have the Haythera Sustena Trinza. We have Latuda tablets, as well as the generic Lorazepam preferred. Generic olanzapine, which varies with different formulations. You'll see there's tablets and solutions. We have quetiapine tablets, Risperdal Consta, generic risperidone with different formulations preferred. And then we also have Vraylar, which is preferred, and ziprasidone generic, and looks like that was it. As far as the antipsychotic combinations, the two products that live in that class are the Symbyax and the olanzapine fluoxetine, which this is the generic of the Symbyax. And you can see that that is non-preferred. And then the last class is the Parkinson's psychotic disorder with only one product in that class, which is Nuplazid, and that product is preferred. And I can take any questions from the DUR board.
Thank you, Marissa. Questions from the board? Okay, hearing none. I believe we have a number of stakeholders for this section, and I believe Leeta had to step away to deal with a matter. So I think Laura is going to help us out as we start going through, Laura Crocker, as we start going through some of these stakeholders. Laura, I have a list, and maybe we can get through that list, and then if anybody else has signed up beyond that, we can address them. How does that sound?
This is Laura. That sounds great.
Okay, first on my list, and please correct me if I pronounced your name wrong, is Nirmal Guman from Janssen Scientific Affairs. Are you with us, Nirmal?
I'm here. Can you hear me okay?
Yes, I can. If you don't mind introducing yourself, who you represent, any conflict of interests, and then Laura will start your 3 minutes.
Certainly. My name is Nirmal Guman, and I'm with Janssen Scientific Affairs, and I have no other conflicts of interest.
Thank you.
Hello, my name is Nirmal Guman again, and I'm a pharmacist and principal scientific account lead with Janssen Scientific Affairs. Thank you for this opportunity to speak to you about Invega Half-Ura, a once every 6-month injection indicated for the treatment of schizophrenia in adults after they have been adequately treated with either Invega Sustenna for at least 4 months or Invega Trinza following at least 1 3-month injection cycle. Please refer to the full prescribing information for complete information. Long-acting injectables are recommended for schizophrenia patients who are non-adherent, partially adherent, or frequently relapsing in response to therapy, or when the patient's care environment is such that an LAI is a more reliable route of administration. The American Psychiatric Association practice guidelines for the treatment of patients with schizophrenia also recommend that LAI should be used in patients with a preference for LAI. Data suggests approximately 40% of patients have difficulty adhering to a daily oral treatment regimen. LAIs promote treatment adherence and transparency by ensuring that patients with schizophrenia receive a known quantity of medication at appropriate dosing intervals. LAIs have been shown to be superior to oral antipsychotics in reducing relapses, hospitalizations, and in increasing adherence. In patients with schizophrenia, use of LAIs is associated with approximately 30% lower risk of mortality compared with oral antipsychotics. The long-term safety and efficacy of Invega Half-Ura was evaluated in an international open-label extension study where patients who remained relapse-free in the double-blind study were given the option to receive Invega Half-Ura for up to 24 months. 96.1% of patients were relapse-free at 24 months. No new safety signals were identified, and no deaths were reported. A systematic review and meta-analysis of real-world comparative studies that reported hospitalizations, ER admissions, healthcare costs, or medication adherence in adults with schizophrenia treated with LAI versus oral antipsychotics was conducted. Of the 25 studies included, 14 studies included Medicaid data. Compared with patients treated with oral antipsychotics, patients initiated on LAIs had 38% lower odds of hospitalization, 25% fewer all-cause hospitalizations, and 14% fewer all-cause ER admissions. Patients initiated on LAI treatment were 89% more likely to be adherent to their medication. Higher pharmacy costs associated with LAI initiation were offset by lower medical costs, which resulted in no significant net cost difference. Thank you for your time and consideration today. I'm happy to answer any questions.
Thank you very much, Nirmal. Any questions from the DUR board? Okay, hearing none. Thank you for your presentation. Next on our list is Jasmine Acosta from Intracellular Therapeutics. Are you with us, Jasmine?
I'm here. Can you hear me?
Yes, I can. Please go ahead and introduce yourself, who you represent, and any conflict of interests, and we'll start your time.
Thank you. My name is Jasmine Acosta, and I'm a senior medical science liaison. I represent Intracellular Therapies, and I have no other conflicts of interest.
Thank you.
So thank you for the opportunity to speak with you today about lumateperone, brand name Caplyta. Caplyta is an atypical antipsychotic indicated for the treatment of adults with schizophrenia and depressive episodes associated with bipolar 1 or bipolar 2 disorder as both monotherapy and adjunctive therapy with lithium or valproate. Caplyta's approval for the treatment of bipolar depression in adults was based on 2 positive pivotal clinical trials. In both 6-week monotherapy and adjunctive therapy studies, Caplyta 42 milligrams statistically separated from placebo on the primary efficacy outcome the MADRS total score, and on the key secondary outcome based on a clinician-rated scale, CGI-BPS. The most common adverse reactions with Caplyta 42 milligrams in both short-term studies were somnolence, sedation, dizziness, nausea, and dry mouth. Mean changes from baseline in metabolic parameters, including fasting glucose, insulin, total cholesterol, triglycerides, and body weight were all similar to placebo. Prolactin level changes and motoric adverse effects during these studies were also similar to placebo. No single TEAE led to discontinuation in 2% or more of patients. In a 6-month open label trial of Caplyta in patients with bipolar depression, there were no new safety signals observed with longer-term treatment, and efficacy was maintained. Similar to other drugs in the antipsychotic class, Caplyta has box warnings not to be used to treat elderly patients with dementia-related psychosis and to closely monitor for worsening or emergence of suicidal thoughts and behaviors. The safety and efficacy of Caplyta have not been established in pediatric patients. Additional warnings and precautions are described in the full prescribing information. In April 2022, the FDA approved 2 new dose strengths of Caplyta, 21 and 10.5 milligrams, for use in patients with moderate or severe hepatic impairment and patients taking strong or moderate CYP3A4 inhibitors. Thank you for considering Caplyta in your formulary discussion. I welcome any questions you may have.
Thank you very much. Questions from the DUR board? Okay, hearing none. Thank you for your presentation. Next on my list is Madeline Shirtleff from Otsuka, representing 2 products with a 5-minute time. Are you with us, Madeline?
Yes, can you hear me?
I can. Please go ahead and do your introduction and we'll start your time.
Okay, so my name is Madeline Shirtleff and I'm a pharmacist and a managed market liaison with Otsuka, and I have no other conflicts of interest.
Thank you.
Okay, thank you for this opportunity to provide information on Abilify, Asimtufii, and Rexulti. Schizophrenia and bipolar I disorder are chronic psychiatric conditions affecting 1.1 and 2.1% of the US population respectively. Relapse and adherence remain a concern for patients with these conditions. Long-acting injectable antipsychotics are used for the treatment of these conditions and are associated with significant improvements in treatment adherence, lower rates of relapse, and reduced risk and length of hospitalization. Abilify Asimtufii is the first and only extended-release long-acting injection indicated for treatment of both schizophrenia and bipolar I disorder in adults. The efficacy of Abilify Asimtufii in adults with schizophrenia or bipolar I disorder was established based on a pharmacokinetic bridging study. 266 patients were randomized to either receive 4 injections of Abilify Asimtufii 960 milligrams every 8 weeks or 8 injections of Abilify Maintena 400 milligram every 4 weeks. Both Asimtufii and Maintena showed similar aripiprazole concentrations. Patients showed plasma concentrations above the efficacy threshold of 95 nanograms per milliliter, which is associated with 4.41 times less likelihood of relapse. The safety profile between the 2 drugs was similar, with most commonly observed adverse reactions being increased weight, injection site pain, akathisia, and anxiety. Building on the proven efficacy of Abilify Maintena, Abilify Asimtufii offers comparable efficacy and tolerability with 2 full months of sustained efficacy in patients with schizophrenia or bipolar I disorder. In fair balance, I call your attention to the box warning for Abilify Asimtufii of increased mortality in elderly patients with dementia-related psychosis. Otsuka respectfully asks that Abilify Asimtufii be included on the formulary for Washington Medicaid members with no restrictions. I would also like to take this opportunity to provide an indication update on Rexulti. On May 10, 2022, Rexulti became the first and only treatment indicated for agitation associated with dementia due to Alzheimer's disease. Rexulti is not indicated as an as-needed treatment for agitation associated with dementia due to Alzheimer's disease. Agitation is a common neuropsychiatric symptom that presents alongside cognitive decline. Agitation is among the most complex, stressful, and costly aspects of care. Agitation is associated with greater caregiver burden, earlier nursing home placement, and increased morbidity and mortality. The frequent occurrence of agitation associated with Alzheimer's dementia, combined with its serious consequences for patient and caregivers, make it a key target for treatment. The efficacy of Rexulti in the treatment of agitation associated with dementia due to Alzheimer's disease was demonstrated in two 12-week randomized double-blind placebo-controlled fixed dose studies, Study 6 and Study 7. In these studies, patients were required to have a diagnosis of probable Alzheimer's disease and exhibit sufficient agitation behaviors at the time of entry to warrant use of pharmacotherapy. Patients in Study 6 were randomized to an oral dose of either Rexulti 1 mg daily, 2 mg daily, or placebo. Patients in Study 7 were randomized to an oral dose of Rexulti 2 mg daily, 3 mg daily, or placebo. The primary efficacy endpoint in these two studies was the change from baseline at week 12 in the Cohen-Mansfield Agitation Inventory Total Score. The CMAI is a clinician-rated questionnaire consisting of 29 items, which assess the frequency of manifestations of agitated behaviors in elderly patients based on caregiver input. In Trial 6, patients in the Rexulti 2 mg group showed statistically significant improvement in the total CMAI score compared to patients in the placebo group at week 12. In Trial 7, patients in the Rexulti 2 mg, 3 mg group showed statistically significant improved total CMAI scores compared to patients in the placebo group at week 12. The 1 mg once daily dosing of Rexulti is not approved and not recommended for the treatment of agitation associated with dementia due to Alzheimer's disease. In fair balance, I call your attention to the box warnings for Rexulti. First, increased risk of suicidal thoughts and behaviors. And the second box warning has changed a bit and is now increased mortality in elderly patients with dementia-related psychosis without agitation associated with dementia due to Alzheimer's disease. OTSCA respectfully requests that Rexulti be available for patients with agitation associated with dementia due to Alzheimer's disease with no restrictions on the Washington Medicaid formulary. I'm happy to answer any questions on either product. Thank you.
Thank you very much. Any questions for Madeline from the DUR board? Okay, hearing none. Next on my list is Mandeep Sohal. Mandeep, you show on my list twice. So if there are two products you're looking to represent, we could do 5 minutes for the two products unless you worked out a separate arrangement.
No, it's just one product.
Okay. Please feel free to introduce yourself, who you represent, and any conflict of interest, and we'll go ahead and start your time.
Hi, my name is Mandeep Sohal. I'm a pharmacist with Teva and Medical Affairs as a Value, Evidence, and Outcomes Liaison. I'm here to provide, no conflicts of interest to report. I'm here to provide information about Uzedy extended release injectable suspension. Uzedy is a long-acting subcutaneous injection containing risperidone, one of the most commonly prescribed atypical antipsychotic drugs. Uzedy was approved in April for the treatment of schizophrenia in adults. Uzedy leverages an innovative copolymer technology and was specifically developed to overcome limitations with currently available long-acting injectables, LAIs. Uzedy provides a combination of product attributes that differentiate it from other current LAIs. Therapeutic plasma concentrations are achieved within 6 to 24 hours following the first subcutaneous injection, meaning no oral supplementation or loading dose is required at treatment initiation. Uzedy is supplied as a single-dose prefilled syringe that can be administered without reconstitution and is ready to use after 30 minutes at room temperature for injection in the back of the arm or abdomen. Uzedy can be administered subcutaneously once monthly or once every 2 months at doses of 50 to 250 milligrams of risperidone, comparable to 2 to 5 milligrams per day of oral risperidone. Uzedy is the only risperidone LAI with a 5 milligram oral dose equivalent. In the current LAI marketplace, Uzedy is the only Q2-month risperidone LAI, thereby allowing for additional flexibility, which may allow for improved transition planning for patients discharged from an acute care setting in light of increased demand for mental health services today. Additionally, receiving an injection every 2 months may allow for patients in underserved rural areas or with other access challenges such as limited transportation or time off restrictions from work, more flexibility receiving their injections. Uzedy was studied in RISE, a phase 3 double-blind randomized relapse prevention study that compared the efficacy and safety of Uzedy Q1 month and Q2 month with placebo across 544 patients with schizophrenia. It significantly decreased risk of relapse by 80% for the Q1 month injection and 62.5% for the Q2 month injection compared to placebo. After randomization at week 12, PANSS score continued to improve over a 64-week treatment period until end of treatment for Uzedy, but worsened for placebo. UZEDY was also studied in SHINE, a phase 3 multi-center double-blind parallel group study to evaluate the long-term safety, tolerability, and effective UZEDY across 336 patients with schizophrenia lasting up to 56 weeks. UZEDY was well tolerated, and the safety profile was consistent with other formulations of risperidone and the phase 3 study. UZEDY has a boxed warning. Elderly patients with dementia-related psychosis treated with antipsychotic drugs are at an increased risk of death. Please refer to the PI for complete safety information. In closing, I respectfully ask the members of the committee to consider allowing access of UZEDY for Apple Health patients. Thank you for this opportunity to speak.
Thank you very much for that presentation. And any questions from the DUR board? Okay, hearing none. We move on to Erin Nowak from AbbVie.
Hi there. My name is Erin Novak. I'm a medical outcome science liaison with AbbVie, and no conflicts of interest to report.
Thank you.
So I am here today to talk about cariprazine, or brand name Vraylar. And I know that Vraylar is on the PDL. However, I would like to provide some updates and unique aspects to this therapy. And then I also have an ask at the end of my testimony. And cariprazine is now approved for the adjunctive treatment to antidepressants for the treatment of major depressive disorder in adults. And other indications include schizophrenia, acute treatment of manic or mixed episodes of bipolar 1 disorder, and the treatment of depressive episodes associated with bipolar 1 disorder. Cariprazine is the only branded atypical antipsychotic approved for all 4 of these indications. It is one of only 2 monotherapies that are FDA approved for treating the full spectrum of bipolar 1 disorder episodes, including manic, mixed, and depressive episodes. And it is the only treatment approved for the full spectrum of bipolar 1 disorder that is considered metabolically neutral with low risk of weight gain and minimal sedation. Additionally, cariprazine has 3 characteristics which distinguish it from others in the class. Number 1, cariprazine's unique pharmacologic profile. And while the precise mechanism of action is not fully characterized, it is known that cariprazine is a D3 and D2 partial agonist and is the only D3 preferring atypical antipsychotic. Number 2, with its 2 major active metabolites, cariprazine has the longest effective half-life of the orally available atypical antipsychotics, estimated to be approximately 1 week. And number 3, cariprazine has a neutral metabolic profile with low risk of weight gain and low risk of sedation. The low risk of weight gain is important because weight gain is a common reason for discontinuation with other second-generation atypical antipsychotics. And patients with bipolar 1 disorder and schizophrenia are at an increased risk for early mortality caused by cardiovascular disease. For safety information, including boxed warnings, please review the full prescribing information at rxabbvie.com. And lastly, I'd like to bring up that there is an interesting situation with cariprazine, and although it's on the Washington PDL with a PA, there are 3 step requirements through other atypical antipsychotics, as well as other PA criteria, which make it more difficult to access than non-PDL therapies, which only have 2 step requirements. For your awareness, and in essence, it's more difficult for patients and providers to access cariprazine, a PDL drug, versus non-PDL drugs in this class. And furthermore, with the exacerbation of mental health conditions in the US, states are moving to reduce barriers to access to therapies like cariprazine, with 45 other states having either unrestricted access, 1-step or 2-step management of cariprazine. And with that, I respectfully request that cariprazine be at parity or better to allow equal or favorable access to this molecular entity, notably in light of the unique aforementioned benefits of cariprazine, which may be beneficial for patients with mental health disorders in the state of Washington. I appreciate your time and consideration. Thank you.
Sharon, any questions for Erin from the DUR board? Okay, hearing none. Laura or Lita, if you're back, that was the end of my list. Have any other stakeholders signed up for this section?
I don't see other.
Okay, thank you. Double confirmation. And I would also direct the committee to the committee's attention to 2 letters, which I believe Lita sent out. There were some written stakeholder testimonials. A letter from Dr. Mary Moeller, and as well from a nurse practitioner in the mental health field, Sarah Wellborg. which you should have received in your read aheads. Okay, let's turn our attention to the motion. If there are any questions, we can entertain those. Otherwise, we'll go ahead and entertain the motion.
This is Dmitry Davidov. So with the motion, I move that all products in the drug classes listed on slide 5 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status, and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
This is John McKay, I second.
Thank you very much.
Family, then find a business, create a business. Oh, there's substances in there that have.
I think we're getting a little feedback there. Thank you for the motion and the second from the board. All those in favor, please say aye.
Aye.
And any opposed or abstentions? Hearing none. Okay, the motion passes. Back to you, Umang, for glaucoma agents.
Alrighty. The next class we'll be reviewing will be glaucoma agents. This encompasses adrenergic agents, combinations, beta blockers, those combinations, carbonic anhydrase inhibitors, kinase inhibitors, miotics, and prostaglandins. On the next slide here, glaucoma affects approximately 3 million people in the US. It is the second most common cause of permanent blindness. It is the leading cause of blindness among Hispanics and the second most common among African Americans. Increased intraocular pressure is common in glaucoma and is believed to contribute to the damage to the optic nerve, which can lead to the loss of visual sensitivity and field. However, some patients with glaucoma have normal IOP, and many patients with elevated IOP do not have glaucoma. IOP alone is no longer considered a diagnostic criterion for glaucoma. There are 2 major types of glaucoma, open angle and closed angle. Open angle accounts for the majority of the cases. There's a reduced flow through the trabecular meshwork. In closed angle, the iris is pushed forward against the trabecular meshwork, blocking fluid from escaping. Risk factors for the development of glaucoma include elevated IOP, advancing age, family history of glaucoma, and African American or Hispanic descent. In terms of treatment, the goal of treatment is to maintain the IOP in a range at which the optic nerve head and retinal nerve fiber layer are stable, as well as preserve visual function and quality of life over their lifetime. Patients with primary open angle glaucoma commonly have untreated IOP that is within the normal range. However, decreasing pressure is still beneficial in these patients. For drug-specific updates, first we have Omlanti. In September of last year, FDA approved this medication, which is a relatively selective prostaglandin E2 receptor agonist for the reduction of elevated intraocular pressure in patients with open angle glaucoma or ocular hypertension. In terms of warnings and precautions, there can be changes for pigmentation, eyelash changes, ocular inflammation, and macular edema. For dosage, the recommended dose is 1 drop in the affected eye once daily in the evening. And the availability, as you can imagine, is an ophthalmic solution containing 0.002% of the main product here. And then next we have, and I apologize to the committee if I mispronounce this, Liuze. In December of last year, the FDA approved this medication for the reduction of elevated intraocular pressure in patients with open angle glaucoma or ocular hypertension. It is an F2 alpha analog, and the warnings and precautions, as you can imagine, are very similar to the previous slide: pigmentations and eyelash changes. Recommended dosage, again, 1 drop in the affected eye once daily in the evening, and it contains 0.005% latanoprost in an ophthalmic solution. In terms of additional drug-specific updates, in January of this year, FDA approved the first generic to Allergan's Alphagan P from Apotex. And in March of this year, Apotex voluntarily recalled 6 lots of brimonidine tartrate 0.15% ophthalmic solutions due to cracks in some of the caps on the bottles. And that is it for this class, relatively straightforward. So I'll pause there for the committee.
Thanks, Umang. What's the news on the PDL, Marissa?
This is Marissa. Sorry, I had a hard time getting off mute. Okay, so going into our glaucoma agents, the first drug class is the adrenergic agents. As you can see here, our preferred products in this class are brand name Alphagan P and generic bromonidine. Moving on to the combinations class, the preferred product in this class is both the generic bromonidine dorzolamide and the brand name Simbrenza. Moving on to the beta blockers, our preferred products in this class are levobunolol and timolol. It looks like in different kind of types of formulations. And then we have, it looks like brand name Timoptic. Into the combination beta blockers, we have generic bromonidine, timolol, and brand name Combigan, generic dorzolamide, timolol, and those are different types. And then there's a ton of combination products here, timolol, bromonidine, dorzolamide, and then there's some that have latanoprost in it as well, and those are all preferred. In our carbonic anhydrase inhibitors drug class, we have brinzolamide and dorzolamide, both generic preferred. Kinase inhibitors, we have Ropressa and Rocklatan preferred. In the miotic drug class, we have phospholine iodide. And then the last one is prostaglandins, and that one we have generic latanoprost, and it looks like that is it in the drug class. And I can take any questions from the board.
Thank you, Marissa. Any questions for Marissa from the board? Okay, hearing none. So I don't have any stakeholders on my list, Lita. Has anybody popped in?
There's no hands raised.
Okay, let's have a look at the motion.
Oops.
Thanks, Lita. Okay, board, so any thoughts or modifications needed, please go ahead and speak up. Otherwise, we will entertain a motion.
This is Laura Bestie. I move that all products in the drug classes listed on slide 7 are considered safe and efficacious for the medically accepted indications and are eligible for preferred status and grandfathered discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Dmitry Davidov, I second.
Thank you, Laura. Thank you, Dimitri. All those in favor, please say aye.
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 Okay. Any opposed or abstention? And the motion passes. Thank you, everybody. And Umang, back to you for hematopoietic agents.
Okay. So the next few topics, there weren't any significant clinical updates. So Dr. Park, I'm gonna just be bouncing it back to you for a few topics here in a row. First one here we have our thrombopoiesis stimulating proteins falling under hematopoietic agents. No significant clinical updates here. So back to you, Dr. Park.
Thank you. Hot potato. Okay, Marissa.
Sorry, I was muted and I was talking. This is Marissa. So for our PDL, for the TPO, thrombopoiesis stimulating proteins drug class, our preferred product in this class is Promacta. And I can take any questions from the board.
Okay, it looks like there are no questions. I see one stakeholder. Manthan Dave, or it might be Manthan Dave. Please correct me if I'm saying your name incorrectly.
Yeah. Hi. Can you hear me?
Yes.
Yeah. Hi. Yeah. No. Actually, you said my last name perfectly. And my first name's Mantan.
Mantan.
Yeah.
Great. Thanks for joining us. Feel free to introduce yourself, who you represent, any conflict of interest, and we'll go ahead and start your time.
Great. Wonderful. Well, thank you, Alex. So, hi, everybody. My name is Mantan, and I am a pharmacist representing Sobi for our product today, which is Doptelet, and I am the medical science liaison on the medical affairs team. So today, I just wanted to take some time to share some updates on our TPRA, and I have no conflicts of interest, yeah, I should be good to go. So I just want to shine some light on our product, Doptelet, known as avatrombopag, which was approved by the FDA on June 26, 2019 for the treatment of thrombocytopenia in adult patients with chronic immune thrombocytopenia who had an insufficient response to a previous treatment. Chronic ITP is one of the most common causes of thrombocytopenia and is associated with excessive bruising, bleeding, any severe and potentially fatal conditions such as any GI or intracranial hemorrhages. And unfortunately, conventional first-line treatments such as steroids and IVIG have variable and transient efficacy and significant toxicities that come with it, which then results in relapse and then ultimately can lead to discontinuation for patients. So prior to the approval of avatrombopag, TPO receptor agonists approved for second-line use required either subcutaneous administration in the physician's office or had significant food-drug interactions. However, with Doptelet, it's an oral drug that does not need to be administered in a physician's office. It does not have any food type interactions, and it does not come with a box warning. The efficacy of avatrombopag in adult patients with chronic ITP was evaluated in our phase 3 clinical trial, which had a primary efficacy endpoint, which looked at the number of weeks in which the platelet count was above 50,000 in the absence of rescue therapy. And looking at our key secondary endpoint, it looked at a proportion of patients that achieved a 50,000 platelet count on as soon as day 8. And after the 6-month trial, patients who had received avatrombopag had a significantly greater median cumulative number of platelet count compared to the placebo. Overall, it just showed that they had a greater proportion of patients who did really well on avatrombopag, and some of the most common treatment emergent adverse events included headache, fatigue, epistaxis, upper respiratory tract infections, and nasopharyngitis. So ultimately, avatrombopag is a viable treatment for options for the thrombocytopenia in adult patients with chronic ITP. And according to the 2019 ASH guidelines, there's actually no step-through therapy that would be needed for Doptelet. So just the first-line agents, and if that doesn't work for patients, Doptelet can be a great TPO receptor for patients moving forward, and has a great response rate for quite some time. So thank you again for this opportunity, and I appreciate being able to voice some education on Doptelet.
Oops, now I'm on mute. Thank you very much, Mantan.
Okay,
Questions from
Alex.
the DOR board? Okay, hearing none. Lita, has anybody else popped in for this section?
There's no other hands raised.
All right. Let's have a look at the motion. Any modifications? Go ahead and let us know, anybody on the board. Otherwise, we'll await a motion.
As Peter Barquette, I can make a motion. I move that all products in the hematopoietic agents thrombopoiesis stimulating proteins class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Kavita Chawla. I second the motion.
Thank you, Peter. Thank you, Kavita. All those in favor, please say aye.
Aye.
Any opposed or abstentions? And the motion carries. Thank you. Let's see, Umang, I think we're on ophthalmic agents.
Yes, sir. Next, we'll have ophthalmic immunomodulator agents here. No significant clinical updates in the last year. So Dr. Park, hot potato back.
All right, thanks, Umang. Marissa.
This is Marissa. So getting into our PDL, our AHPDL for the ophthalmic agents immunomodulators, our preferred products in this class are generic cyclosporine, brand name Restasis, and brand name Zedra. And I'll be happy to take any questions from the board.
Anyone have a question for Marissa? Okay. Let's see. No stakeholders on my list, Lita.
I don't see any hands raised.
Great. Okay, let's look at the motion. By the way, committee, we're 2 sections away from what Lita and I are planning to be a break, so hang on tight. We're almost to a place where we can have a little breather. Any concerns or questions about the motion as it stands, please go ahead and let us know. Otherwise, we'll entertain a motion.
This is John McKay. I move that all products and all ophthalmic agents, immunomodulator class, are considered safe and efficacious for their medically accepted indications, and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Peter Barquette. I'll second that motion.
Thanks, John. Thanks, Peter. All those in favor, please say aye.
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 And any opposed or abstentions? Okay, and the motion carries. Let's see, Umang, we're on respiratory agents.
Yes. Next one, we have idiopathic pulmonary fibrosis. Again, no significant clinical updates in the last year.
Okay, thanks, Umang. Marissa.
This is Marissa. So looking at our respiratory agents, pulmonary fibrosing agents, drug class, our preferred products in this class are brand name Esbriet, OFEV brand, and then generic pirfenidone. And I'll be happy to take any questions from the board.
Okay, hearing none. Thank you, Marissa. Any hands raised, Lita?
There's no hands raised.
Okay, let's turn our attention to the motion for respiratory agents. And we'll entertain a motion.
Dmitry Davidov here. I move that all products in the respiratory agents, pulmonary fibrosing agents class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is John McKay, I second.
Thank you. All those in favor, please say aye.
Aye.
And any opposed or abstention? And the motion passes. Okay, Umang, what's the news on smoking deterrence?
The next one we have smoking deterrence, essentially smoking cessation agents, no significant updates here.
That is too bad. I know my patients could use some other options. It's a hard thing to fix. Okay, Marissa, what do we got on the PDL list?
This is Marissa. So looking at our smoking deterrence miscellaneous other drug class, we have pretty much all of the products preferred in this class, which you can see is varenicline, bupropion ER, and then the generic Chantix, which I think brand name Chantix is not, I think it's been pulled from the market or recalled. So that's why you don't see it listed here, but the generic is apparently still available. So we have everything preferred. And I'll take any questions from the board.
Any questions from the board? Okay. Any stakeholders, Lita?
There are no hands raised.
Okay, let's turn our attention to the motion.
This is Kavita Chawla. I move that all products in the smoking deterrence miscellaneous other class are considered safe and efficacious for their medically accepted indications and are eligible for their preferred status, grandfathering at the discretion of HCA. Products in this class may require prior auth to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Peter Barkett. I'll second the motion.
Thanks, Kavita. Thanks, Kavita. Thanks, Peter. All those in favor, please say aye.
Aye.
Any opposed or abstentions? Hearing none, and the motion passes. Okay, committee, Lita and I thought this would be a good time to have a quick break, and then we'll come back and finish out our business. How long do we have, Lita?
10 minutes. So let's see, I guess it's close enough to 1:50. You want to come back at 2?
Works for me.
Okay,
All right, see you then.
thank you. Hi, this is Lita. If all the committee members could turn on their cameras so we know when you're all back.
We got everybody, Lita? Are we in good shape?
Umang, are you back? Oh, there he is. Okay, yeah, looks like it.
All right, welcome back, everybody. And we're going to continue with Umang and bone density regulators.
Umang, you're on mute.
I'm so sorry. All righty. The next 4 classes will be similar to how the last 2 or 3 were. The first being bone resorption, suppression, and related agents. So there are no significant clinical updates in the last year for this class. We'll right back to Dr. Park.
Thanks, Umang. Over to Marissa.
This is Marissa. So looking at our bone density regulators, rank ligand inhibitors drug class, we have Prolia and Xgeva both in that class, and both of those products are preferred on our AHPDL. And I can take any questions from the board.
I hear silence, so I assume that means no questions. And I don't have any stakeholders, Lita. Has anybody signed in?
No, there's no hands raised.
All right, let's move on to the motion.
This is Dmitry Davidov. I move that all products in the bone density regulators, rank ligand inhibitors class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second the motion.
All right, thank you. All those in favor, please say aye.
Aye.
Any opposed or abstentions? Okay, the motion passes. Let's see, Umang, endocrine and metabolic agents.
Alrighty, next we will have, there we go, growth hormone releasing hormones, which falls under the endocrine and metabolic agents. Again, no significant clinical updates for the drug in this class.
Okay. Thank you, Umang. Marissa?
This is Marissa. Sorry, I just wanted to note, it looks like actually you guys will be doing, the DUR board will be doing one motion for both the endocrine and metabolic agents, growth hormone releasing hormones, and the growth hormones drug class. So it looks like, Umang, there's no updates to this drug class either. I don't want to speak for you if I'm incorrect. So just wanted to let you know that it's 2 classes it looks like we'll be doing. I don't know if there's stakeholders in both, but I can go through the PDL for both of those classes. So first is the GHRH drug class. And in that drug class, we just have Egrifta, and that is preferred. And then getting into the growth hormones drug class, we have several products preferred, which it looks like is genotropin, nortotropin, and it looks like just those 2 products are preferred in that drug class. So I can take any questions from the board regarding those 2 drug classes.
Thanks, Marissa. I'm not hearing any questions. I think we did have at least one stakeholder, Paul Miner, for the GHRH class. Are you with us, Paul?
Yes, hello. Can you hear me, Alex?
Yes, I can.
Okay, great. Well, thank you very much. I'll proceed with my comment. I have I'm an employee of Ascendis Pharma, and I have no additional conflicts to report. So I'll begin. My name is Paul Miner, and I'm a pharmacist and national director for field health economics and outcomes research for Ascendis Pharma. I'd like to request that the committee recommend, well, I can see it's already a thank you for the addition of Skytrofa to the Washington Medicaid PDL as a non-preferred agent. While we understand that utilization management strategies such as step therapy, prior authorization, and quantity limits are essential to help lower costs by encouraging the use of safe and less expensive medications, unintended overly restrictive criteria could prevent patients access to innovative therapies for intolerant patients that could reduce patient care burden and improve outcomes supported by literature and compendia. So getting the right patient on growth hormone is essential, and the criteria address that very well. However, approval criteria sometimes unintentionally are too restricted. So failing a daily growth hormone prior to the approval of a long-acting growth hormone makes sense, which there are now 2 long-acting growth hormones on the market, one just recently approved. I understand that if failing 2 preferred agents prior to receiving a non-preferred agent makes sense when all of the therapies consist of the same medication, in this case, daily somatropin. And it's been that way for a couple of decades. So I think the mindset is that, this is very similar. Skytrofa or Lonapeg somatropin is a long-acting prodrug of somatropin. It's approved by the FDA for once-weekly subcutaneous treatment of growth failure due to inadequate secretion of endogenous growth hormone. It is a prodrug that consists of 3 components: an unmodified parent drug, human growth hormone, and that's really important, and an inert carrier and a proprietary linker that binds the 2. This product predictably releases fully active, unmodified parent somatropin over a 1-week period, and it's designed to allow the same tissue distribution, receptor activation, and therapeutic effects of efficacy and safety and tolerability as daily growth hormone formulations. Now, weekly administration can reduce the number of injections by 86%, and there are many patients that fail daily growth hormone due to injection burden and must, by current criteria, have to fail a second daily prior to a long acting. And that's really the question here. and with the time they have, reasonably, we respectfully request that the criteria currently in place for Skytrofa and other long-actings have a language that would consider approval criteria allowing access to a long-acting growth hormone such as Skytrofa following a single failure of an existing preferred agent, as they are all daily growth hormones, the current preferred agents, albeit maintaining existing PA clinical criteria, which I think is important. I thank you for your consideration and welcome any questions. This really does offer a great opportunity for these patients.
Thanks, Paul. Questions from the board for Paul? Okay, hearing none. Has anyone else signed in? Rita?
There's no other hands raised.
Okay. Let's turn our attention to the motion. So this is one motion for the two classes.
This is Kavita Chawla. I move that all products in the drug classes listed on slide 14 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred.
Dimitri Davidoff, I second.
Thank you. All those in favor, please say aye.
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 And any opposed or abstention? And hearing none, the motion passes. Let's see, I think this is the last section, Umang, and I think we have updates in this section. Oncology agents.
Alrighty, yes and no, Dr. Park. So with oncology agents, as the committee can imagine, Magellan does break these classes down by disease state. So the first one being prostate cancer. Apple Health PDL does break these down. They go a step further and break it down by mechanism of action. And as you can imagine, a lot of these medications can be used for various different oncology cases, not just prostate cancer. So for the first one, we have androgen biosynthesis inhibitors in anti-androgens. I'm going to pause here for the prostate cancer. There is no significant clinical update for this subclass. I will ask Marissa if you would like me to go through all of oncology or pause through each one.
This is Marissa. Yeah, Umang, you can go through all of them because we'll be doing one motion for all of the oncology agents. And if you need a water
Perfect.
break, feel free to take one in between. I know it's a lot of content.
Oh, I'm ready. Okay. Yes. So perfect. Thank you, Marissa. This is going to be all oncology for the next few remainder of the slide deck, I believe. So buckle in. Alrighty. Next we have oncology oral hematologic. And so under this, there are subclasses that fall in here. First being anti-neoplastics miscellaneous, hedgehog pathway inhibitors. We have multi-kinase inhibitors, TKIs. I apologize, I doubled up on those. So these are the ones that fall under here. Moving right along to the next slide here, we have, as you can imagine, there are numerous classes that fall under this class. And so I've bolded the ones that do have significant clinical updates. Here you can see we have an update for lenalidomide, Brukinsa, and Imbruvica here. So moving right along into a little bit of background. First, again, just as the committee can imagine, the hematologic oncology section has a lot of different disease states that fall under this. And so I've tried to kind of focus on the ones that are updated, that are respective to the clinical updates. There are a lot of other disease states that I won't go over, but they can be found in the therapeutic class review if the committee wished to take a look at that. The first here we have graft versus host disease. An immune-mediated disease that can result following hematopoietic stem cell transplant when the transplanted cells, the graft, recognize the recipient's body as foreign. Organ systems Most commonly impacted by acute graft versus host disease include the skin, GI tract, and liver. Chronic graft versus host disease is generally an extension of acute graft versus host disease that often develops more than 100 days after transplant, but it can also occur in those without acute graft versus host disease. Symptoms include ocular manifestations, oral or GI manifestations, respiratory, and neuromuscular. In terms of treatment, the American Society for Bone and Marrow Transplantation, renamed the American Society of Transplantation and Cellular Therapy in 2019, published a clinical practice guideline in 2012 around the first and second line treatment of acute graft versus host disease. The guidelines state that the corticosteroids are the standard of care for the initial treatment, and note that the literature does not support the choice of any specific agent for secondary therapy. The guidelines were published prior to the May 2019 FDA approval of Jakafi for the treatment of corticosteroid refractory acute graft versus host disease in the adult and pediatric patients 12 years of age and older. In 2019, the NCCN published their first set of clinical practice guidelines around hematopoietic cell transplantation. These recommend ruxolitinib as a category 1 option for patients with steroid refractory acute graft versus host disease. The NIH recommend that corticosteroids are most commonly the initial systemic therapy choice for most patients with moderate to severe chronic graft versus host disease. Adjunctive supportive care may also be used, such as artificial tears, artificial saliva. Ibrutinib was the first drug approved for chronic graft versus host disease in patients who have failed one or more systemic treatment, but many other therapies have been used off-label and for primary or secondary therapy. And the NCCN guidelines list ibrutinib as category 2A recommendation for steroid refractory chronic graft versus host disease, along with multiple other agents also listed as category 2A recommendations. On the next slide here, we'll pivot over to Waldenstrom's macroglobulinemia. And so this is a B cell disorder presenting as bone marrow infiltration with lymphoplasmacytic cells that are CD19, 20, and 22 positive. The NCCN guidelines recommend treating only those patients who are symptomatic. These symptoms include hyperviscosity, neuropathy, symptomatic adenopathy, or organomegaly, amyloidosis, cryoglobulinemia, and cytopenias. Both zanubrutinib and ibrutinib, with or without rituximab, are listed as options for primary treatment, both category 1 preferred, while ixazomib combined with rituximab and dexamethasone is category 2A, other recommended regimen for primary therapy. For patients who have received previous therapies for Waldenstrom's macroglobulinemia, zanubrutinib and ibrutinib with or without rituximab are category 1 preferred regimens. Acalabrutinib is a category 2A, other recommended treatment option. Up to 40% of Waldenstrom's macroglobulinemia patients may have recurrent mutations in the CXCR4 gene, and certain CXCR4 mutations may confer resistance to ibrutinib. Therefore, the NCCN guidelines recommend consideration of CXCR4 gene mutation testing for patients being initiated on ibrutinib therapy as a category 2A, useful in certain circumstances recommendation. No current US guidelines exist for the treatment of erythema nodosum leprosum, hypereosinophilic syndrome, or chronic eosinophilic leukemia here. Moving onward to chronic lymphocytic leukemia or small lymphocytic lymphoma. CLL is classified as NHL and is the most prevalent adult leukemia in Western countries. It is generally a disease of the elderly, usually diagnosed around the age of 70 years. A small percentage of patients undergo Richter's transformation of their disease to an aggressive lymphoma. The treatment is highly individualized, as some patients may only require observation and other patients may be candidates for cytotoxic or biologic therapies. CLL and SLL are different manifestations of the same disease. In CLL, a significant portion of the abnormal lymphocytes are in the blood as well as in the bone marrow. In SLL, there's a relative lack of abnormal lymphocytes in the blood. Instead, abnormal lymphocytes are found predominantly in the lymph nodes, bone marrow, and other lymphoid tissues. In the 1950s and 1960s, alkylating agents, including Leukeran combined with corticosteroids became the standard of care for patients requiring treatment for CLL. The role of chlorambucil in the current day management of CLL, SLL is combined with obinutuzumab only if 65 years of age or younger patients with significant comorbidities. For patients without the del17p p53 mutation and patients who have indications for treatment. In terms of treatment, the NCCN guidelines recommend for first-line therapy include monotherapy of ibrutinib as another recommended regimen. Category 1 recommendation for all CLL, SLL patients without del17p TP53 regardless of age or comorbidities. Preferred regimens include Calquence with or without Gazyva, Venclexta, Gazyva, and Brukinza regardless of age or comorbidities for first-line therapy of patients without the del17p TP53 mutation. Moving onward to mantle cell lymphoma is technically classified as an aggressive lymphoma, possesses characteristics of both indolent and aggressive NHLs. The median overall survival is approximately 4 to 5 years, but there is no evidence of a survival plateau, which is similar to indolent lymphomas. The chromosomal translocation of the T1114 is usually present in MCL, and it is highly resistant to conventional chemotherapy and displays an aggressive disease course. In terms of treatment, the 2022 B-cell lymphoma guidelines indicate that lenalidomide plus rituximab is one of the several regimens that may be utilized for induction therapy when a less aggressive regimen is indicated. In the second-line setting, all BTK inhibitors, including Calquence, Imbruvica, with or without rituximab, and Brukinza, as well as lenalidomide plus rituximab, are listed as preferred. The NCCN guidelines note that acalabrutinib and zanubrutinib have not been shown to be effective for ibrutinib refractory MCL with the BTK C481S mutation. However, patients with intolerance to ibrutinib have been successfully treated with acalabrutinib or zanubrutinib without recurrence of symptoms. Venetoclax with or without rituximab is a category 2A, useful in certain circumstances recommendation. Okay, moving on to drug-specific updates. First, we have lenalidomide. Last year, FDA approved the generic for Revlimid, 2.5 mg and 20 milligram capsules from Dr. Reddy's. Secondly, we have a manufacturer communication. In April of this year, the manufacturer for Imbruvica, AbbVie, announced plans to voluntarily withdraw the accelerated approval for use in patients with mantle cell lymphoma who have received one or more prior therapies for marginal zone lymphoma who require systemic therapies and have received one or more prior anti-CD20 based therapies. The other FDA-approved indications will remain as is, and the withdrawals are based on findings from the confirmatory trials for these uses at a requirement for the accelerated approvals. On the next and final slide here, we have Brukinza. And here you can see in January of this year, FDA approved a new indication for the treatment of adults with CLL or SLL. Other previously existing indications include mantle cell lymphoma, Waldenstrom's macroglobulinemia, and marginal zone lymphoma. No changes to any of the warnings and precautions, as you can see listed here. The dosing for the new indication, 160 milligrams twice daily or 320 milligrams once daily. It is recommended to reduce the dose in patients with severe hepatic impairment. No changes to formulation here either. And that is it for the for this oncology class. Since as per Marissa's instructions, we'll just keep going through the oncology subclasses. Next here we have oncology oral for breast cancer. This does encompass subclasses such as anti-neoplastic miscellaneous combinations, cyclin-dependent kinase inhibitors, PARP inhibitors, and TKIs as well. Alrighty, next here we have, so a little bit of background. Breast cancer is the most common site of cancer for women in the United States, accounting for 30% of all cancer diagnoses. and is second only to lung cancer as a cause of cancer death in American women. It is estimated that there will be roughly 287,000 new cases of breast cancer diagnosed in the US in 2022. There'll be an estimated 43,500 deaths. The incidence of breast cancer in US women continues to increase by about 0.5% a year. Known risk factors that may be contributing to this increased incidence of breast cancer include a decline in fertility rates and an increase in body weight. Despite this increasing incidence, death rates from breast cancer have declined by 42% since 1989, largely due to improvements in both early detection and treatment. The overall 5-year survival for women diagnosed with breast cancer is 99%. Patients who present with localized disease have a 98.9% 5-year survival rate. However, prognosis for patients presenting with distant metastatic disease is much poorer, with a 5-year survival rate of only 29%. Breast cancer is most frequently diagnosed in women between the ages of 55 to 64, with a median age of diagnosis age being 62 years. Rarely, this can occur in men. Other risk factors include various endocrine, genetic, environmental, and lifestyle factors. Some of these risk factors are modifiable, some are not, and the impact of these are variable. Next, we have, in terms of treatment, so historically, the role of neoadjuvant chemotherapy is limited to breast cancer patients with inoperable, locally advanced disease. But contemporary breast cancer treatment protocols now often include neoadjuvant therapy. There are several reasons for this expanded role of neoadjuvant therapy. First, it can increase the likelihood of patients being able to undergo breast-conserving surgery. Second, studies have shown that patients with triple-negative breast cancer and those with HER2-positive disease who achieve a pathologic complete response, defined as the absence of invasive disease in the breast and lymph nodes following neoadjuvant therapy, have an improved prognosis. Recently published research have focused on response to neoadjuvant treatment as a predictive marker and a guide for selecting subsequent adjuvant therapy. For the ASCO guidelines regarding neoadjuvant chemotherapy, endocrine therapy, and targeted therapy, recommend neoadjuvant therapy with any of these modalities if the patient has inflammatory breast cancer or if the patient has unresectable or locally advanced disease at presentation such that the disease may be rendered resectable with neoadjuvant treatment. Furthermore, the guidelines state neoadjuvant systemic therapy should be offered to patients with high-risk TNBC in whom the findings of residual disease at time of surgery would guide recommendations related to adjuvant therapy. Regarding neoadjuvant endocrine therapy, the guidelines state that postmenopausal patients with HR-positive, HER2-negative disease may receive a neoadjuvant aromatase inhibitor therapy to increase local regional treatment options, or if there is no intent for surgery, endocrine therapy may be used for disease control. However, for premenopausal patients with HR-positive, HER2-negative early stage diseases, neoadjuvant endocrine therapy should not be routinely offered outside of a clinical trial. So next we have the subclasses that I mentioned at the beginning of the slide deck, or excuse me, this subclass. There are 4 mechanisms of actions that fall under this umbrella: antineoplastics, CDK inhibitors, PARP inhibitors, and TKIs. The bolded medications reflect the ones that will be reviewed here: Ibrance, Verzenio, and Tukysa. So moving right along to Ibrance. In December of last year, FDA expanded the indication for the treatment of adult patients with HR-positive, HER2-negative advanced or metastatic breast cancer in combination with an aromatase inhibitor as initial endocrine-based therapy, and it's been expanded to include pre- and perimenopausal women. No other changes to other indications, no changes to warnings or dosing or availability, just the expansion of the patient population for the indication here. Next, we have Tukysa. In January of this year, FDA approved a new indication in combination with trastuzumab for treatment of adults with RAS wild-type, HER2-positive, unresectable, or metastatic colorectal cancer that has progressed following treatment with fluoropyridine, oxaliplatin, and irinotecan-based chemotherapy. Again, no changes to anything else in terms of warnings or availability, and the recommended dosage for this New indication is 300 milligrams taken twice daily, irrespective of food. And the last slide for this subclass, we have Verzenio. So March of this year, the indication was expanded to include one, use in combination with endocrine therapy, tamoxifen or an aromatase inhibitor for the adjuvant treatment of adult patients with hormone receptor positive, HER2 negative, node positive, early breast cancer at high risk of recurrence. Previously, it was only indicated for use in patients with a Ki-67 score greater than or equal to 20% as determined by an FDA-approved test. And two, in combination with an aromatase inhibitor as an initial endocrine therapy for treatment of adult patients with HR positive, HER2 negative, advanced or metastatic breast cancer. And this indication was only for treatment of postmenopausal women and men. It doesn't change any of the other indications here. Recommended dosage here if it's in combination with fulvestrant, tamoxifen, or an aromatase inhibitor is 150 milligrams twice daily. If it's monotherapy, it's 200 milligrams twice daily. No changes to the availability here. Okay. Now moving on to this next subclass, other. And so as the committee can imagine, in our therapeutic class review for this, numerous disease states fall under other. This can be bladder cancer, central nervous system cancer, cholangiocarcinoma, colon cancer, et cetera, et cetera. However, we'll kind of review the subclasses that make up this in the Apple Health PDL and then the respective significant clinical updates. So on the next slide here, you'll see the subclasses that make this up in the Apple Health PDL. We have the anti-neoplastic miscellaneous combinations, FGFR kinase inhibitors, MEK inhibitors, multi-kinase inhibitors, PARPs, tropomyosin receptor kinase inhibitors, and TKIs. The specific drugs that we'll be reviewing here, we have Litgovi, Pemazir, Rubraca, Zejula, Jaypirca, and Turalio. I'll be going over the respective disease states that go along with the drug-specific updates. So first, we have cholangiocarcinoma. These are tumors originating in the epithelium of the bile duct. They're typically classified as either intrahepatic or extrahepatic, depending on their location within the biliary tree. It is rare in the US, where about 8,000 people are diagnosed per year. This may be an underestimate of the actual number of cases because these cancers are difficult to diagnose and may often be classified as other types of cancers, such as hepatocellular carcinoma or cancer of unknown origin. The average age at diagnosis is between 70 and 72 years of age. Treatment includes a surgical consultation to assess if the patient is a candidate for resection or possible organ transplantation. For patients with unresectable or metastatic disease, there is an increasing role for molecular profiling. Intrahepatic cholangiocarcinoma harbors IDH1/2 mutations in 10 to 23% of cases, and mutations in FGFR2 fusions occur in 13 to 14%. The prognostic significance in intrahepatic cholangiocarcinoma is unclear, but FGFR mutations may improve prognosis. Additionally, these mutations provide an opportunity for targeted therapies. The NCCN guidelines on hepatobiliary cancers include infigratinib as potential therapeutic regimen in the subsequent line therapy setting for biliary tract cancers if disease has progressed on or after systemic treatment for unresectable or metastatic disease. It is listed specifically as a regimen for being useful in certain circumstances for cholangiocarcinoma with FGFR2 fusions or rearrangements. And pemigatinib is also recommended as a category 2A for these patients. So the first medication here, Litgovi. In January of this year, FDA approved Litgovi, which is a FGFR inhibitor for adult patients with previously treated unresectable, locally advanced, or metastatic intrahepatic cholangiocarcinoma harboring FGFR2 gene fusions or other rearrangements. Continued approval is based upon confirmation of clinical benefit. In terms of warnings, there can be ocular toxicity. It can cause retinal pigment epithelial detachment. It is recommended to perform a comprehensive ophthalmologic examination, including the optical coherence tomography prior to initiation of therapy, every 2 months for the first 6 months, and every 3 months thereafter, and urgently at any time of visual symptoms. And secondly, embryo fetal toxicity. It can cause fetal harm. So it is recommended to advise patients of reproductive potential of the potential risk to the fetus and to use effective contraception. In terms of dosage, it is recommended to confirm the presence of the FGFR gene fusion or other rearrangements prior to treatment. The recommended dose is 20 milligrams orally once daily until disease progression or unacceptable toxicity occurs. And the availability are 4 milligram tablets. Next, we'll pivot over. Next, we have ovarian cancer, which is the 5th most common cause of cancer-related death in women in the U.S. It increases with age, with the median age being 63 years and 5-year survival is 49.7%. More than half of patients present with advanced disease. Ovarian cancer has been shown to have a higher prevalence in families with BRCA1 or BRCA2 genotypes, and in patients, the onset of disease is usually at a younger age. However, patients with these mutations account for only 15% of all ovarian cancers. In terms of guidelines, the NCCN recommend primary treatment for advanced ovarian cancer usually begins with cytoreductive surgery to remove as much of the gross disease as possible, because patients with more complete debulking have better outcomes. The majority of patients, excluding those with very early stage diseases, are recommended to receive postoperative adjuvant systemic chemotherapy. Recommended protocols generally include a taxane or a platinum agent. Intraperitoneal chemotherapy is recommended in addition to intravenous chemotherapy in certain clinical situations. A newer class of orally targeted agents, the PARP inhibitors, are also available for the treatment of ovarian cancer. There are currently 3 FDA-approved PARP inhibitors for the use in ovarian cancer on the market, which include Zejula, Lynparza, and Rubraca. Lynparza was the first PARP inhibitor approved by the FDA in late 2014, and approval was limited to patients who had a germline BRCA mutation, advanced disease, and received 3 or more previous lines of chemotherapy, and this indication was withdrawn August of last year. Since that time, the FDA approved indications and the role of PARP inhibitors in ovarian cancer has expanded. Selection of patients with advanced ovarian cancer who have a high likelihood of responding to PARP inhibitors has also been expanded to include patients identified as being homologous recombination status HR positive. HR positivity is defined as having either a deleterious BRCA mutation and or a genomic instability as identified by an appropriate test. Zejula is approved for patients who have received 3 or more prior lines of therapy and whose cancer is associated with an HR positive status, while Rubraca is approved for patients who have received 2 or more lines of chemotherapy and have an identified deleterious BRCA mutation. So next we have Zejula. So in December of last year, the indication for maintenance treatment of recurrent epithelial ovarian fallopian tube or primary peritoneal cancer had been restricted to only patients with deleterious or suspected deleterious germline BRCA mutated cancers who are in complete or partial response to platinum-based chemotherapy. In April of this year, the FDA approved the use of Zejula 100 milligrams, 200, and 300 milligrams for 1, maintenance treatment of adults with advanced epithelial ovarian, fallopian, or primary peritoneal cancer who are in complete or partial response to first-line platinum-based therapy, and 2, maintenance treatment of adults with deleterious or suspected deleterious germline BRCA mutated recurrent epithelial ovarian, fallopian tube, or primary peritoneal cancer who are in complete or partial response to platinum-based chemotherapy. No changes to anything else such as warnings, dosage, or availability here. Next we have Rubraca. So here in December of last year, the indication for maintenance treatment of recurrent Ovarian cancer has been restricted to patients with a deleterious BRCA mutation. Statement added that an FDA-approved test for the detection of deleterious germline and/or somatic BRCA mutations is not currently available. And the MDS AML section of the warnings and precautions was updated to include data in patients with BRCA-mutated recurrent ovarian cancer. No other significant changes here in regards to warnings, dosage, or availability. Alrighty, next we have Pemazyre. So in September of last year, the FDA approved the new indication for the treatment of adults with relapsed or refractory myeloid or lymphoid neoplasms with fibroblast growth factor receptors, FGFR1 rearrangement. No changes to warnings and availability. And with this new indication comes a new recommended dosing of 13.5 milligrams once daily. And you continue this until disease progression or unacceptable toxicity. Next, we have update for Turalio. In October of last year, the approved dosage changed from 400 milligrams twice daily on an empty stomach to 250 milligrams twice daily with a low-fat meal. The approved dosage form is now 125 milligram capsules, and 200 milligram capsules are no longer approved. And lastly, for this subclass, next we have is Jaypirca. In January of this year, FDA granted an accelerated approval to this kinase inhibitor indicated for the treatment of adults with mantle cell lymphoma after 2 or more lines of systemic therapy, including a BTK inhibitor. Again, this indication is approved under accelerated approval based on response rate. Continued approval for this indication may be contingent upon verification and description of clinical benefit in a confirmatory trial. Warnings for this medication include embryo fetal toxicity, things such as infections, hemorrhage, cytopenias, all that you would imagine with an immunosuppressive agent, and atrial fibrillation and atrial flutter. The dosage is 200 milligrams orally once daily, and it is recommended to manage toxicity using the treatment interruption, dosage reduction, or discontinuation. And the availability here are 50 and 100 milligram tablets. On the next slide, we'll be moving right along to lung cancer. This class will have topoisomerase inhibitors, tropomyosin receptor kinase inhibitors, and TKIs as well. Giving a little bit of background here for lung cancer. It is the leading cause of cancer death in both men and women in the US. In 2023, an estimated 238,000 new cases of lung cancer will be diagnosed and 127,000 deaths are estimated to occur. Currently, a 5-year survival is estimated to be 23%, an increase of 15% reported in 2019. Declines in lung cancer mortality in the US have been accelerated in recent years. And from 2005 through 2014, lung cancer mortality declined 3%, but from 2014 through 2020, this decline more than doubled, resulting in a 5.3% decline in lung cancer mortality over that period. Additionally, there has been a steady decline in the incidence of lung cancer diagnoses in the US. The number of diagnoses declined 2.3% in the most recent measurement. Despite these encouraging trends, there's still more US lung cancer deaths annually than deaths from breast cancer, prostate cancer, and colorectal cancer combined. The primary risk factor for the development of lung cancer is smoking tobacco, accounting for approximately 85 to 90% of all cases of lung cancer. The carcinogenic chemicals in the cigarette smoke are responsible for most lung cancer-related deaths, while exposure to secondhand smoke also results in an increased relative risk of developing lung cancer. While chemoprevention agents are not yet established in lung cancer screening using low-dose computerized tomography is recommended by the U.S. Preventative Services Task Force, who expanded their lung cancer screening guidelines in 2021. The guidelines now recommend the annual screening for patients 50 to 80 years of age who are current smokers with at least a 20-pack year smoking history and former smokers who have quit within the past 15 years. Okay, with lung cancer, there are a lot of mutation-specific guidelines, and I'll do my best to kind of specify those. The first being EGFR sensitizing mutations. So the NCCN guidelines have been updated to incorporate the use of Tagrisso in the adjuvant setting of the earlier stage NSCLC. The guidelines recommend that the use of Tagrisso with stage 1B to 3A disease who have undergone complete resection with EGFR exon 19 deletions or exon 21 L858R mutation disease, who receive previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy. For patients with an EGFR exon 20 insertion, positive metastatic disease with disease progression, the guidelines recommend Exkivity as an option for subsequent therapy. The ASCO and the Ontario Health guidelines this year have recommendations regarding stage 4 non-squamous cell lung cancer with driver mutations. They indicate that Tagrisso should be offered in the first line setting for patients with T790M, L858R, or exon 19 deletions. And if Tagrisso is not available in the first line setting, gefitinib with chemotherapy or dacomitinib may be offered. Other options listed by the guidelines include afatinib or erlotinib with bevacizumab, erlotinib with ramucirumab, or gefitinib, erlotinib, or isatinib, which is not available in the US as single agents. For BRAF V600E point mutations, for patients with advanced or metastatic lung cancer who are found to have BRAF V600E mutations, a combination of dabrafenib plus Mekinist is recommended as first-line therapy by NCCN, while single-agent vemurafenib may be an option if the combination of dabrafenib plus tramitinib is not tolerated. According to the ASCO guidelines, patients with stage 4 NSCLC and BRAF V600E mutations should be offered dabrafenib and tramitinib in the first line setting. For patients who receive targeted therapy in the first line setting, second line therapy should consist of standard non-driver mutation guideline recommendations. Continuing with more targeted therapy, with MET exon 14 skipping mutations, both Trabecta and Tepmetko are listed as NCCN Category 2A preferred options, while Xalkori is listed as Category 2A, useful in certain circumstances, recommendation. ASCO guidelines recommend offering Trabecta or Tepmetko in the first line setting. And if the patient does not receive one of these therapies in the first line setting, it may be offered in the second line setting. In terms of ALK rearrangements, ASCO 2021 updated guidelines regarding patients with stage 4 NSCLC who harbor an ALK rearrangement recommend that alectinib or brigatinib be offered in the first line setting. The guidelines recommend that if alectinib or brigatinib are not available, patients should be offered ceritinib or crizotinib. The ASCO guidelines also outline drug choices for second line setting. Lorlatinib is the second line setting. In the second line setting is recommended if the patient receiving alectinib or brigatinib in the first line setting. Patient receiving crizotinib in the first line setting, then alectinib, brigatinib, or ceritinib should be offered. And in the third line setting, lorlatinib may be offered. For ROS1 rearrangements, ASCO guidelines recommend crizotinib or entrectinib in the first line setting. Other options include ceritinib or lorlatinib. And if targeted therapy was given in the first line setting, then guidelines recommend the standard treatment based on non-driver mutation guidelines should be followed. And for the last targeted therapy, we have RET arrangements and NTRK fusions. So for both Gavreto and Retevmo, they're listed as Category 2A preferred first-line agents in NCCN guidelines. ASCO guidelines state that Retevmo or standard therapy based on non-driver mutations may be offered in the first line. At the time of the publication, Gavreto recommendation in the first line setting was provisional pending confirmatory data. and recommendations for second line setting for RET rearrangements are dependent on the therapy received in the first line. If targeted therapy with Gavreto or Retevmo were not given in the first line setting, they may be offered as a second line therapy. And lastly, for NTRK fusions, both Roslitrek and Vitrakvi are category 2A preferred options in the first line. ASCO guidelines also recommend Roslitrek and Victravi in this setting, and these drugs may also be offered in the second line setting for patients with NTRK gene fusions who did not receive them in the first line setting. Okay, so here we have the subclasses broken down. As I mentioned at the beginning, we have topoisomerase inhibitors, tropomyosin receptor kinase inhibitors, and TKIs. The two drug updates in this class that we'll be reviewing will be gefitinib and Retevmo. First, we have Retevmo here on the next slide. In September of last year, the FDA granted accelerated approval for Retevmo for patients for adults with locally advanced or metastatic solid tumors with rearranged during transfection gene fusion that have progressed on or following prior systemic treatment, or who have no satisfactory alternative treatment options. It is also indicated in certain patients with RET fusion positive non-squamous cell lung cancer, RET mutant medullary thyroid cancer, and RET fusion positive thyroid cancer. No changes to dosages here or warnings or availability. And lastly, just a quick update, FDA approved the first generic to AstraZeneca's Iressa from Apotex, which is gefitinib. Okay, moving right along. Next we have oncology, renal cell carcinoma. These include subclasses such as the mTOR kinase, multikinase, and TKIs, but no significant clinical updates in this subclass. We shall move right along to skin cancer. And the subclasses in this are BRAF kinase inhibitors, hedgehog pathway inhibitors, and MEK inhibitors as well. A little bit of background. Melanoma skin cancer, the incidence in the US is increasing, but the death rate due to melanoma is declining. From 2002 to 2006, the incidence of melanoma increased at a rate of 33% for men and 23% for women. Melanoma is increasing more rapidly than any other malignancy except lung cancer in women. Conversely, there have been recent declines in mortality for melanoma. From 2009 to 2013, the death rate for melanoma was stable, but from 2014 to 2018, the mortality due to melanoma declined 5.7% annually. In the US, it is estimated that there will be 106,000 new cases of melanoma diagnosed in 2021, and there will be an estimated 7,000 deaths due to melanoma. Median age at diagnosis is 65 years of age. Risk factors for the development of melanoma include both genetic factors and environmental factors. Despite the relationship to UV exposure, melanoma can also occur in areas of body without substantial sun exposure and can occur in any ethnic group. There are also non-cutaneous forms of melanoma arising from melanocytes present in mucosal membranes or the uveal tract of the eye. The treatment of non-cutaneous melanoma may differ from that of cutaneous melanoma, and treatment should be individualized for these patients. Here on the next slide, we have the three subclasses: BRAF kinase inhibitors, hedgehog pathways, and MEK inhibitors. And we will have updates for Tafinlar, Cotellic, and Mekinist. So the first one we have here is Tafinlar. March of this year, FDA approved in combination with Mekinist for the treatment of pediatric patients greater than 1 year of age with low-grade glioma with a BRAF V600E mutation who requires systemic therapy. Presence of BRAF V600E mutation in tumor specimens must be confirmed prior to treatment. An FDA-approved test for detection of this mutation is not currently available. The recommended dosage is 150 milligrams twice daily. For pediatric patients, it is individualized based on body weight, and the dosing for this is 10 milligrams tablets for oral suspension. Keep in mind this new indication is for both Tafinlar and Mekinist. I just kind of combined it here. Next, we have Cotellic. So November of last year, FDA approved a new indication for adults with histiocytic neoplasms as monotherapy. It already had a secondary indication, as you can see. No changes to warnings or dosage availabilities. For dosage, it is recommended to confirm the presence of BRAF V600E or V600K in tumor specimens prior to initiation. And the recommended dosage is 60 milligrams orally once daily for first 21 days of each 28-day cycle until disease progression or unacceptable toxicity. And then on the next slide here, we have retinoids. And so still in oncology, retinoids, per the Apple Health PDL, the only drug that falls under this is tretinoin. And there is no significant clinical update for this class. And so I will pause there. Thank you for the committee for being patient as I fumble through half of those names and pass it back to Dr. Park and the committee.
Thank you, Umang. You did great. That was another complicated set. We kind of started the day complicated and we're ending the day complicated. Questions for Umang from the DUR board? Okay. And I have Marissa coming up on the screen now with the oncology agent list.
This is Marissa. So I will briefly go through the oncology agents. Overall, our management strategy for really these products is you'll see that a lot of the oncology products are typically preferred unless there is a generic on the market. So if there's like a brand and generic, typically we like to prefer the generic over the brands. That's where you'll see a product typically be non-preferred. Otherwise, that product, the oncology products typically tend to be preferred on our AHPDL. So you can see here, I'll go through it pretty quickly. I'll just call out pretty much all of the preferreds. We have abiraterone acetate, and then moving on to the anti-androgens, we have generic bicalutamide, Erleada, Ulexin, flutamide, Nalandro, nilutamide, Nubeca, and Xtandi. Moving on to anti-neoplastics miscellaneous combinations, all the products are preferred, which are Inqovi and Kisqali and Lonsurf. For BRAF kinase inhibitors, we have Braftovi, Tafinlar, and Zelboraf. Hopefully I'm pronouncing these correctly. I don't know if I am. For cyclin-dependent kinases, we have Ibrance, Kisqali, and Verzenio. Those are all preferred. For FGFR kinase inhibitors, we have Balversa, Litgobi, Pemazir, and Truseltic. Those are preferred. The hedgehog pathway, it looks like this one is blank. This might be an error. I'll have to double check what that product is in this class. So I apologize for that. For the MEK inhibitors, we have Cotellic, Koselugo, Mechanistic, and Mektovi, which are all preferred. For mTOR kinase inhibitors, we have, it looks like generic everolimus, which is preferred. For multi-kinase inhibitors, oral, all the products are preferred, which are Fotivda, Nexavar, Rydapt, Sorafenib, Stivarga, Sunitinib, Sutent, and Tepmetko. Next are the polypolymerase inhibitors, Lynparza, Rubraca, Talzenna, and Zejula. Those are all preferred. For the retinoids, like Umang mentioned, it's just tretinoin, which is preferred, and that's generic. For the topoisomerase inhibitors, we have one product, which is Hycamptin, and that is preferred. For tropomyosin receptor kinase inhibitors, we have Rozlytrek and Vitrakvi. I might be pronouncing that incorrectly. Those are all preferred. And then TKI inhibitors or tyrosine kinase. This is a pretty large class, but the preferred products are Alecensa, Alunbrig, Avakit, Bosulif, Brukinza, Cabometyx, Calquence, Caprelsa, Cometric, Erlotinib, Exkivity, Gavreto, Gavitinib, Gylotrif, Gleevec, that is actually non-preferred, that's a brand name. Iclusig, generic Imatinib, Imbruvica, we have Inlida, different lapatinib, Lenvima, there's different formulations. Lorbrena, Nernlix, Kinlock, Retevmo, Scemblix, Sprycel, Tabrecta, Tagrisso, Tasigna, Tuxia, Turaleo, Tycurb, Vizimpro, Votrient, Xalcori, Zospata, and Zycadia. So quite a bit of preferred products in that class. And it looks like that is it. So I can take any questions from the DUR board.
Thanks for going through that, Marissa. Any questions from the DUR board? Do you have a question, Dimitri? No. Okay, let's see. So I think we have at least one stakeholder here for this section under the heading of tyrosine kinase inhibitors. Long Win from GSK, are you with us?
This is.
Yes, I am.
Okay.
Hi, this is Long Win. Can you hear me?
Yes.
Yes. Good afternoon. And my name is Long Win, and I am a pharmacist with GSK Medical Affairs team, and I have no other conflicts of interest. Thank you, Umang, for providing a great overview on the PARP inhibitors. And not trying to repeat what Umang has said, I'd like to add 2 key points. One, patients that are diagnosed with ovarian cancer presented with many different tumor types, like Umang mentioned. These patients can have a BRCA mutation or a BRCA wild type with HRD, which stands for homologous recombination deficiency, or HRP. Per NCCN guidelines for ovarian cancer treatment, all PARP inhibitors are recommended as first-line maintenance in patients with BRCA mutation as monotherapy, especially for those who has either a complete or partial response to platinum-based chemotherapy. However, majority of these ovarian cancer patients have a different type of tumor that presented as a BRCA wild type with HRD or HRP confirmed by an FDA-approved companion diagnostic test. For these patient population, up to 75% of these patients, Zejula is the only PARP inhibitor that can be used as a monotherapy without the need to use in combination with a VEGF inhibitor or bevacizumab like other PARPs. Secondly, with the approval of Zejula tablet in April of this year, the tablet formulation will provide patients some advantages over the current 100 milligram capsule formulations. Patients now can take 1 Zejula tablet once daily, regardless of dosage. The Zejula tablet does not contain gelatin, which allow use in patients with related dietary restrictions. And Zejula capsule will be discontinued once tablets are available on August 1st. So these are a couple of key points I want to differentiate Zejula with other PARPs inhibitor according to the NCCN guidelines recommendations and dosage availability. So thank you to the committee for the time, and I will be happy to address any questions.
Thank you very much. Any questions from the DUR board for Long? Okay, hearing none. Thank you for your presentation. Lita, has anybody else signed in to represent on this topic?
There's no other hands raised.
Great.
Oh, wait, we just got one.
Oh.
Paul Forsberg.
Hi, good afternoon. My name is Paul Forsberg. I'm a licensed pharmacist with Pfizer Oncology Medical Affairs. I have no other conflicts of interest at this time, and I'd like to discuss Ibrance.
Thank you. Please go ahead.
Great. I am here to provide the committee with efficacy and safety information for Ibrance, palbociclib, the first FDA-approved oral CDK4/6 inhibitor approved for hormone receptor-positive, HER2-negative metastatic breast cancer. Ibrance 125 milligram capsules and tablets are indicated for the treatment of adult patients with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer in combination with aromatase inhibitor as initial endocrine-based therapy or fulvestrant in patients with disease progression following endocrine therapy. Recommended starting dose of Ibrance is 125 milligram capsule taken orally once daily with food, or 125 milligram tablet taken orally once daily with or without food. Capsules should be taken for 21 days, followed by 7 days off in a 28-day cycle in combination with either an aromatase inhibitor or fulvestrant. In PALOMA-2, a phase 3 trial of postmenopausal women with estrogen receptor positive, HER2 negative metastatic breast cancer treated in the first-line setting, Ibrance plus letrozole demonstrated a median progression-free survival of 24.8 months versus 14.5 months with placebo plus letrozole with a hazard ratio of 0.58. Neutropenia was most frequently reported all-grade adverse reaction in PALOMA-2 trials at 80% respectively. Febrile neutropenia has been reported in 1.8% of patients exposed to Ibrance across the PALOMA clinical trials. Monitoring CBC prior to the start of Ibrance therapy is recommended at the beginning of each cycle, as well as on day 15 of the first 2 cycles as clinically indicated. Severe life-threatening or fatal interstitial lung disease and/or pneumonitis can occur in patients treated with CDK4/6 inhibitors, including Ibrance. Ibrance can cause fetal harm, and advising patients of potential risk to fetus and to use of effective contraception is recommended. In conclusion, maintaining Ibrance, an oral inhibitor of CDK4/6 on your formulary, will continue to offer additional treatment options for patients with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer in the Washington Medicaid population. Based on the efficacy and safety of Ibrance, I respectfully request that the committee continue to make Ibrance available to your patients. Thanks for your time, and I'd be happy to address any questions that you may have.
Thank you very much. Any questions from the board? Okay, hearing none. Anybody else, Lita?
There are no other hands raised.
Okay, let's look at our motion. This is kind of a mega motion. It incorporates all those subclasses that Umang went through. Any comments from the board? If not, we'll entertain a motion.
Dimitri Davidoff.
Oh, go ahead.
I move that all products on the drug classes listed on slide 16 and 17 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
So Peter Barkett, I'll second the motion.
Thank you. All those in favor, please say aye.
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 And any opposed or abstention? And the motion carries. And the next item on the agenda would have been the Apple Health policy, but I know we have to wait for Ryan to come back and work through that one with us. So we'll defer that till the next meeting, which I think is in August. And is there any other business, Lita?
No, that is it. Thank you guys so much and have a great summer, or we'll see you in August. It's almost, I guess we'll still be summer, whatever.
All right, thanks.
Thanks,
Bye.
everybody. See you
Thank
next time.
Thank you. Bye.
Thanks everyone.